and that metabolic health is cardiovascular health. Metabolic health is mental health. Metabolic health is, autoimmunity, right? It's linked to so many different aspects. So the focus, I think, really needs to be on metabolic health.
What would you like other cardiologists and maybe just, primary care physicians to know about the ketogenic diet?
Yeah, I think before talking about the ketogenic diet, I think we have to talk about metabolic health and the importance of metabolic health. And that metabolic health is cardiovascular health. It's not one or the other. They are one and the same. Metabolic health is mental health. Metabolic health is, autoimmunity, right? It's linked to so many different aspects. So the focus, I think, really needs to be on metabolic health. And then once you acknowledge that, then you can see the effect a ketogenic diet has on metabolic health. And it is better than anything we have. It's better than any nutritional intervention, is better than any drug in terms of lowering insulin and lowering glucose and improving triglycerides and HDL and the size of your LDL particles, the things that are related to metabolic health and blood pressure, like the one-stop shop for all that. I think it's not that it's the only way to achieve those goals, but I think from a lifestyle intervention, it is the most effective. So the first is recognizing the importance of metabolic health. And the second is recognizing the impact ketogenic diets have on metabolic health. And once you can put those two together, there's no turning back, because that's when it needs to be an option, at least an option for just about everybody you see who is overweight or has type 2 diabetes or prediabetes or insulin resistant or autoimmune conditions or any concerns with metabolic health. It at least needs to be an option that you can offer in that subset, and then know how to follow people appropriately. And that's a lot about what we do at Diet Doctors, providing as much information as we can so people know how to either start a diet themselves or start a patient or client on it, and then how to follow over time to make sure there can be side effects, there can be changes in labs, and we have guides about all these things to help the clinicians through that process. Because we don't want there to be barriers for them to not start people who could benefit from a ketogenic diet or versions of low carb diets.
And so what would be, you've mentioned a couple of times now, someone who's metabolically healthy versus like someone who might be more deranged. What are some of this is maybe our foray into labs. We've talked about LDL particle. What's the number that you like to see on a lab? And then what constitutes from when we're looking at diagnostic criteria or results on a lab, what are some of the things that you like to say where you're saying, okay, like this, let's say their glucose looks like this. Like, what are some of the markers that you like to see on a lab that would help you say with confidence, this is a metabolically healthy individual?
Yeah. So one is definitely the size of your LDL particles. One is definitely your triglyceride to HDL ratio. One is your VLDL or your remnant particles, because that's frequently associated with metabolic dysfunction. And then getting away from the lipids, glucose is a big one, but fasting glucose is probably the least helpful. Really, you want to know what your glucose is during the day, your average daily glucose, your glucose excursions with meals, how high does it go and how long does it stay elevated? Hemoglobin A1C can help as like a 3-month average. And then, of course, insulin levels, which are something that really not enough physicians are checking. Fasting insulin levels are good. A lot of people have heard the Kraft test, which is even better, but it's a challenging test to order for a lab to know what to do. And so fasting insulin is a good place to start, certainly. You can calculate
what's the number that you like there? Like 5 to 7-ish, or what's the number?
Yeah, it's I don't love to just give numbers because improvements is always something. Like I have a patient I see whose fasting insulin always sits around 15, and that's phenomenal because he started at like 50, right? And no matter what we do, we haven't been able to get it below 15, but I don't care because everything else has fallen in line.
Right.
So that's an example. But I think if you're going to give a number, like, below 8, below 5, somewhere in that range is where you want your fasting. But I do want to put a caveat there. It really does have to do with where you're starting from in terms of where you want to go. So I wouldn't want someone to say like, I only got it down to like 12. This is terrible. Like, no, if you started at 40, getting it down to 12 is fantastic. And especially if your other markers are moving accordingly. Yeah.
I don't think I've ever seen an insulin at 40. I think I would fall over if I saw that.
Oh boy, they're out there. Trust me. They are out there. Yeah.
So let's talk about the ketogenic diet in this context. So one of the things that I've noticed is when someone goes from, it can be a standard American diet, it can be whatever diet, and they start keto. It has been my observation that some of these labs transiently do get worse. So I have seen, let's say, LDL numbers get worse, total cholesterol tends to get worse. And then for, and maybe we can get into like some of the mechanistic explanation as to why, but I see around the 6 to 9 month mark, things tend to just kind of come back to at least baseline, but usually there's a marked improvement in, let's say, HDL numbers and then the ratios that we've been talking about. Can you talk a little bit about some of the changes that we see when we're first starting a low carbohydrate diet, specifically a ketogenic diet, and then maybe an explanation as to why? Like that's just been my clinical observation, but I suspect you have some insight onto why that's happening.
Yeah. So the things that are almost universally seen are reduction in triglycerides, an increase in the HDL, reduction in the VLDL, an improvement in the size of the particles. Like that's almost universally seen when people start a low carb diet. I guess you could say the tricky part is what happens to LDL. And you're absolutely right. And there's a couple of studies to show this, that it can transiently go up in a number of people over the first 6 months and then come back down over the next 6 months to baseline. So when you look at studies that enrolled people who were overweight, starting a keto diet for weight loss, or who had type 2 diabetes and starting a keto diet for treatment of their diabetes, on average, there is zero rise in LDL on average. Now, if you look at the individuals, of course, there's some have an increase, some have a decrease. But I think that's the most important thing for people to realize, especially for clinicians, or if you're a patient, your doctor tells you you can't start a keto diet because it's going to, your LDL is going to skyrocket. And you'd be like, well, hang on a second. You actually look at the evidence, on average, it doesn't. Okay, but now we spend a lot of time focusing on this subset where it does. And rightly so, because that's what makes most doctors nervous. But because that's what gets the most attention, the most oxygen, the most airtime, whatever you want to say, a lot of people just assume it's a given that your LDL is going to go up or your ApoB is going to go up, and absolutely not. And actually, Virta Health did a great study that they published where the LDL went up 10% on average, but the ApoB did not change at all. And we have to recognize that ApoB is the better marker than LDL. So again, if your LDL goes up 10%, but your ApoB doesn't change, I don't care about your LDL because that ApoB is the better marker. And the way they did that is because the particles got bigger, you got fewer small particles, you didn't have your VLDLs went down, and those all, that makes a difference for ApoB. So
and it's also the lifetime exposure too. And this is what I try to talk to patients about. It's like, let's just assume that your LDL is going to get worse over the next year, let's say.
Yeah.
In the context of your life, it's lifetime exposure that we're actually concerned with, not the year where it went up or even 2 years where it was elevated, right?
Right. And that's something I think is really interesting. If you walk into a doctor's office and have an elevated LDL, they'll throw terms around like you're at high risk of a heart attack, ticking time bomb. You have to lower this right now. No, it's like you're saying, we're talking about 10 to 20 year risk. We're not talking about next week, next month for most people. So I do think that's kind of interesting. And so, when trying to decide what to do about LDL, that definitely has something to do with it, that the time of exposure, but also, again, going deeper and about the ApoB, but then the degree of elevation is really important. So I mentioned a 10% increase. Okay, no big deal, especially if your ApoB is normal. Some people will see like a 50% increase. Some people will see 100 or 200% increase. So those are all sort of different buckets to put somebody into. So there's sort of like the standard response, then there's the hyper responder, then there's what's been termed the lean mass hyper responder. And I think those are the 3 buckets. Sometimes when I give a talk, I'll show 3 Starbucks cups, the tall, the grande, or the venti. So which one are you in terms of your LDL elevation? Because I think it makes a difference in how we see it.
Yeah.
And to simplify, the small elevation, which usually has no rise in ApoB, no problem. The medium elevation, which will usually come with a rise in ApoB, that again, put it into context. And even for the large rise, which will definitely have a rise in ApoB and LDL particle numbers, put it into context, time frame it, And then you can decide if you want to make certain changes in the diet, just like adding 20, 30 grams of carbs can make a huge difference. Adding some fiber can make a big difference. You can make small changes like that to adjust it. Or do you maybe start a medication or a supplement, or do you change the diet? Those are all options, but it should not be a knee-jerk reaction that this is obviously and immediately harmful. That sort of I disagree with. Now, you're asking about mechanism. The mechanisms are still hypothetical at this point, but there are a couple. One is on lower carb diets with lower insulin, you can downregulate LDL receptors on the liver. So that's one mechanism. Another mechanism that's been popularized by Dave Feldman at cholesterolcode.com, and who's actually published some papers on it, and he's really sort of done a great job getting out there in the literature, is the energy delivery model, where you're using triglycerides for fuel. And this has to do, as he describes it, mostly in the lean mass hyperresponder, where we're really dependent on triglycerides for fuel. So we have to create lots of VLDLs from the liver because they have a ton of triglycerides and not much cholesterol. Then they go around in the circulation and drop off the triglycerides basically for energy. And as they do that, they sort of transition into LDL. So that's the natural life cycle of a VLDL, as it transitions into an LDL. So if you have more VLDLs dropping off the triglycerides, you're going to end up with more LDL. So that's another potential mechanism of why this happens, which then can lead to potential ways around it. But the unanswered question is this harmful? Is it in the same category as elevated LDL that's not because of a diet in the setting of metabolic dysfunction? And again, my guess is it's probably not, but the hard part is individualizing it for the patient.
And then when we talk about, the venti cup and I don't go to Starbucks often, but I know venti. So venti, grande, and then I don't remember the last one. If we were to talk about hyper responders, let's say, so you talked about the lean mass hyper responders, what percentage of the population would you estimate that where we have people who do, in fact, my again, clinical, very basic observation has been somewhere around 80 to 90% of people who go on a ketogenic diet are going to be just fine. But it is in that kind of 10, maybe 20% on the high end where we do see further derangement that does not seem to be corrected. Is that in line with the research or in what you see in practice as well?
Yeah, I guess it really depends on your patient population. So if you have a practice of ketogenic athletes, it's going to be 80% who have a rise in LDL, right? And if you have a practice, a weight management practice where everybody has obesity or overweight that you see, it's going to be 5 or 10% maybe, or something like that, right? So it depends on the population. Yeah.
Yeah. And then do you notice any sex differences between men and women and their response on the ketogenic diet long term?
Yeah, it's interesting. I think the general experience is that men tend to lose weight faster and probably lose more weight than women do, which just infuriates women, especially when if it's like a husband wife starting at the same time. Like that's the worst. The husband wife at the same time, and the husband seeing much better results than the wife. But that doesn't mean it doesn't work for women. I mean, it certainly does. And actually, I had a really interesting interview with Dr. Lucia Aronica, who's a researcher at Stanford. And she did an evaluation of this diet fits trial, which they ran at Stanford. And because there was a gender difference, that women didn't respond as well as men. But what she was able to find is the compliance was simply lower. The adherence was lower. And, stereotypically, who's going to sit down and order like a steak and veggies, or who's going to have, a salad with very little protein and, maybe seed oil dressing or whatever, the woman is stereotypically more likely to do that. And the man's more likely to have the steak. And so maybe that has something to do with their hunger, their satiety, their adherence to the diet. So I thought that was a really interesting interview, that there are cultural stereotypes that we're sort of fighting against that may play into it. But assuming even that adherence is the same, you still can definitely see some differences in the speed of weight loss and the absolute amount of weight loss between genders. Yeah.
It's so interesting that you talk about the steak, because there's something, we'll say, just again, painting, as you said, painting broad strokes here.
Yeah.
But there is a similar resistance with eating steak. It's like, man, fire, meat, it's like we sort of like, ascribe this like phenotypically male with steak, and the same is actually true with lifting weights. This is another thing that I talk about on the podcast as well. It's like lift heavy weights. And like my population, the community that listens to this show is primarily a woman. She's somewhere between 35 and 55. Maybe she's in perimenopause, looking like things that worked in her 40s, that worked in her 20s, no longer working in her 40s, which is where we introduce the ketogenic diet for women. And I get the same blowback. I get the same resistance with, you have to eat meat, let's say, or you have to have more protein and lifting heavy weights. It's like, oh, I don't want to get bulky.
Right.
And it's like that.
Right.
When we talk about, you've been talking about metabolic health, those are like the two single biggest improvements that you can make in your metabolic health, your longevity and your health span, is by putting on more lean muscle mass, specifically muscle, as you're moving from a high estrogen, high testosterone environment, premenopausal, and then, kind of going into a lower anabolic hormone environment in menopause. I think that's one of the single biggest things that you can do. And there's that same resistance around that. It's just, it's very interesting. Like meat and weights is like men, and it's not something that's applicable for women, when it so is applicable for women as well.
Yeah, I agree 1,000%, and probably even more applicable for women, because women have that sort of dramatic change in sex hormones or in estrogen and with hitting menopause, where men it's a little more gradual. But when women have that more dramatic change, that's when resistance training becomes that much more important. I mean, it's important throughout the whole life cycle, but I think that's where it becomes even that much more important, because that's when body composition is a little bit more challenging to maintain and improve. And you can't do it without protein and without resistance training. And those are the two things that stereotypically, that you're absolutely right, that women kind of shy away from if we're painting broad strokes, where hopefully messages and examples like yours are really going to help start to change that. Yeah.
Let's just talk about the different types of fasts, so our listeners can kind of get a handle of where we're going with this conversation.
Yeah. And so I think the easiest way to start is to say that the more traditional modalities are like a 16-8, which is 16 hours fasted with an 8-hour feeding window. And I use that as a barometer, because that's the goal, to get people to commit to becoming fat adapted and be able to do it successfully. And from there, there's a springboard to so many variations of fasting. And I think it's important for people to understand that most people don't go from a standard American diet and being a couch potato to going to a 16-8 effortlessly. There's a lot of back and forth to get people there. And I definitely walk people through. As I say, it's like put the training wheels on, because we're going to get some support along the way. But another very popular and talked about quite a bit in women's groups is OMAD, so 1 meal a day. And I think OMAD is definitely can be part of a fasting regime. It's not something I recommend for women in particular to be sustained, because there's just no way to get enough macronutrients into your diet in 1 meal. I can't think of any woman that can eat 100 grams of protein as a starting point in 1 meal. So I think that it's great as a variation. You've gone on vacation, you've overeaten, maybe you went to a celebration and you decided you're just going to have a massive meal and call it a day. It's not something that I like to see sustained. And I see on social media quite a few women that they get, and especially middle-aged women, they get to a point where maybe they aren't as hungry as they once were. And so 1 meal a day feels good because they're really hungry for that 1 meal, and then they're not hungry the rest of the day. And I have to continuously go back to, this is fine as a variation. This is not something we want to sustain. We're not going to be able to nourish our bodies. We're going to send the wrong signals to our brain. We're going to send the wrong signals to our mitochondria and everything else. Other variations are things like a 20/4, which for anyone that is familiar with, this is a little bit of a differentiator. Oftentimes I have people who swear they can get 2 meals in a 4-hour window. I don't know how that's possible, but I do see quite a few men that are able to get an entire day's worth of calories in the 4 hours. I don't see that necessarily being a sustainable long-term solution for a woman. You'll oftentimes see a 5-2, which I've seen this presented 2 different ways. You can have 5 days of a normal eating pattern, which might be 3 meals a day with 2 days of lower calories. Ideally, the research suggests less than 600 for those 2 days for men each day, 500 for women. I think it's far easier just to fast every day than have a day where I'm going to really compress into one meal. You can also see a 5-2 as a variation of fasting, and then having 2 days where you are doing a 24-hour fast. So maybe Tuesday and Thursday, you do a 24-hour fast, and the other 5 days, you're having a normal eating pattern. But as you can see, the one thing about fasting in general, which I love, is that it can be flexible. So you may, throughout the course of a month or throughout the course of a year, you may employ some of these strategies. And the idea is that you can decide for yourself. It's like pulling a lever. Like, this is the lever I want to do today. This is what's going to honor, which is going to work for my physiology, what's going on in my personal and professional life. And this makes a lot of sense. And then maybe the following week, you may transition. And I do encourage a lot of variation in fasting once you're fat adapted, because as I know we'll talk about, hormetic stress is the right amount of stress in the right amount at the right time. And depending on where you are in your cycle or beyond, you may need different types of variations in your fasting regimen.
I've had Dr. Jason Fung on the show, who I know has been on your show as well. And one of the things that he said that I really liked was this idea that fasting is sort of diet agnostic. Like, you can be paleo, you can be keto, you can be insert diet here, right? Like, whatever diet you want to follow, AIP, whatever. But fasting fits into each of them without disturbing, the agreed upon, guideposts that make up that diet, which I think is really important. And so I like how you've outlined these time, like, the 16-8, the OMAD, the 24, the 5-2, which, just as an aside, was super popular a couple of years ago. It's like, it's sort of fallen out of vogue. I feel like, the 16-8 and the 24 and the OMAD, those are really, and I have long, like, I do 12-12 sometimes, like week before my period. Like, there's no way that I'm doing a 16-8. Like, it's like a 10-14.
Yeah.
But the 5-2 has really fallen out of vogue. And I don't mind it so much. Like, I don't mind, that you can say, okay, maybe for 2 days, I'll restrict my calories or bring them down. But I do agree with you. I think that like doing something on the daily, so it's sort of in your habit, like it's habitual for you, is great. Do you differentiate at all between, one of the things that I like to talk about is like water only, like herbal tea, I would classify that as like no calories, like a non-caloric fast, and something like, maybe, when you look at Walter Longo's research, and he has like fasting mimetics, where he has you doing 5 days of, and I forget the calories now, but it's like one day is like 600, one day is 700, one day is 400, whatever. Do you differentiate between that? Or do you think, for just ease of understanding, is it better to sort of stick to the time lever as an initial inquiry into fasting?
That's a great question. I think for ease of understanding and ease of comprehension, I think that sticking to a time frame with a clean fast, like, the bitter teas, the coffee, the water, is a great starting point. I would say probably once a week I get questions about, do I do Prolon? Do I recommend Prolon? And I always say, I think it's always in the context of what's right for you. What are your goals? What are you looking for? Obviously, like longevity research, it's, that's very different than, I guess it's like, I see them very differently, and I see the values of both. But I feel like if I can get people to subscribe to the concept of eating less often as a starting point, then we can always entertain the possibility of longer fasts. I mean, I personally, because I had a 13-day hospitalization in 2019, it's really hard for me to wrap my head around not eating for a period of time, although I understand, like, intellectually, I think it's triggering for me. So I always like to be transparent and say that I haven't done any long fasts since that long hospitalization. But I do value Walter's research. I know that David Sinclair talks a lot about, the same kind of concepts in terms of longevity and protein restriction. I tend to be so slanted towards protein consumption that that's where the differentiator is. Although, again, I see the utility, the research, and the value in what they're doing. I just think it becomes, I start kind of looking at like what's most important, and maintaining and building muscle versus the longevity piece. And so I just haven't quite made complete sense of all that and how to kind of put it together. But I definitely value Walter's research.
I really appreciate your comments, because I have the same cognitive dissonance, right? Like I understand that periodic protein restriction, like we might be talking about in intermittent fasting, can upregulate. We're going to talk about mitochondria. We're going to talk about AMP kinase, autophagy, et cetera. But as you just mentioned, I do think that it is very important for women in particular to be thinking about muscles. And we're going to talk perimenopause today, ladies, and like perimenopause, like that is your preparatory phase for menopause. And if you don't have muscle, when you have, even if your estrogen levels and, your testosterone levels are fluctuating, you still have them. They're still anabolic. You can still build a lot of muscle. If you don't do it in your perimenopausal years, it's not that you can't when you're menopausal. It's just orders of magnitude more difficult because now you are in a permanent low testosterone environment, save for like bioidenticals or HRT or whatnot. So I do think that muscle and bone health, right? Like muscle and bones, they're twinsies. Like you have good, like you're, mechanically stressing the muscle. You're also driving bone density. So women, again, the osteoporosis, concern, my, one of my aunts, she recently was at like a Costco and shopping and fell over. And luckily, like nothing happened. She's fine. But it could have been this woman is like a machine. She walks like a boss, right? She's always walking up and down stairs. She doesn't take the elevator. But I wonder if she wasn't like that and she didn't have, the proprioception and the muscle mass and the bone density, what that might have looked like if she tripped over something when she tripped over a crate or something when she was at Costco. So what would have happened, to her hip, let's say, or her arm when she had her arm outstretched as she was falling down. So very, very important. I'm glad you brought that up because that's where I'm like, and the other piece, we won't get into it now. We'll come back to your book, but I just want to say, women, we need more protein as we age to overcome that anabolic resistance that naturally sets in. So we'll have some offline discussions around that. But all that to say, I agree with you. And I still haven't sorted it out either, because I think there's truth in both camps, right? There's truth in the protein restriction and how that might lead to, sirtuin activation, et cetera. So with that said, let's dive into some granularity with some of the benefits that fasting affords us. And I wanted to talk about the mitochondria to start in particular. And, because I mentioned them, maybe we'll just start with sirtuins. Like what are the effects that intermittent fasting has on our mitochondria, and then follow on how that's related to sirtuin activation?
I think it's a really important discussion because although, we get granular, I think that it helps people understand that fasting is so much more than changing body composition. So when we're talking about the mitochondria, we're talking about the powerhouses of our cells. And it's humbling to me, the more I understand about mitochondria, the more I'm humbled that they work so effectively or should work so effectively. So I think after the age of 40, I think 50% of the population has mitochondrial dysfunction. And so mitochondrial dysfunction is implicated in nearly any chronic disease state. And so obviously, if you have metabolic disease, if you have cancer, there are so much that's impacted by the mitochondria not working effectively. But the beauty is that when we are in a non-fed state, we get upregulation of autophagy and mitophagy, and where our body can effectively go in and get rid of these disease disordered cells, organelles, et cetera. I always liken it to taking out the trash. But the only way that that's really potentiated and magnified is when we're in a non-fed state. And so I get questions all the time, and I'm sure you do too. When does autophagy kick in? When does this mitophagy, when we go in and our body can really potentiate this? And I always remind people that eating less often has so many benefits that, as an example, like if you go 12 hours without eating, are you upregulating autophagy? Not a whole lot, but you're still getting benefit from it. So when people really want to get nuanced, like when do things really ramp up? And I always say the longer you fast, the more autophagy you will potentiate. So over like 18, 24 hours, that's when you'll see significant increases in this. When we're talking about sirtuin activity, again, this is another thing that is upregulated when we're in this non-fed state. And you mentioned some of David Sinclair's work where he's really looking, there are many types of sirtuins, but in a protein fasted state, we know that It will, there are these two kind of opposing forces, like we're looking at autophagy and mTOR activation. And this is another thing people they want to get very granular, like, well, as soon as you eat, then you knock out this, and this has to be upregulated. And I think it's really much more nuanced than that the foods we choose to break our fast with, or the foods that we have on board in our bodies, can upregulate or downregulate some of these processes. And what we really want is balance. Ultimately, that's what we're looking for. Like, obviously, if you're overeating all the time, you're getting very little autophagy. So you've got lots of disease disordered cells that are hanging around that could potentially go on to create problems, health issues, versus if you're, starving and you have no mTOR activation. I mean, guess what's going to happen? Your body's going to go in and break down muscle to use as fuel. This is what happened to me 3 years ago. I hate saying like I was a good case study of this, but you don't eat for 13 days. Guess what happens? Your body catabolizes, breaks down muscle in order to feed your body. And this is not what happens when you fast. That's called starvation. And that was because I was sick and I couldn't eat. But this is an important distinction to talk about finding balance between these different mechanisms in the body that are designed to maintain homeostasis, to make us better, stronger, more resilient. And when we eat too frequently, we knock out that balance. If we don't eat enough food in the right amounts at the right time, we can knock out that balance. So really understanding that on a cellular level with the mitochondria, that we have all these upregulation, downregulation of these mechanisms, that if they're properly balanced, just like hormones and other things in the body, we can feel more energetic, more vibrant, sleep better, maintain muscle, digest our food better. I think it's also like very helpful for people to understand, because they hear the word mitochondria, mitophagy. It's just really speaking about cellular health. And we want to do as much as we can to maintain and support cellular health, because every single organelle in the body is made up of thousands, if not millions of cells. So the healthier each individual cell is, this is probably asking for too much, but the healthier we can make our cells, the better we are going to feel, the more active, the more we can contribute, the more we can serve others, as opposed to what effectively I was told at 43 was, this is just the way things are. And I think that's kind of the conventional prevailing wisdom that's out there, like, oh, aging is expected to have things start to break down. And I don't believe in that. I believe that if we honor our bodies the way that they're intrinsically designed to thrive, that we're going to do a much better job with aging. I don't want to say per se in reverse, but honoring our physiology and being able to support our bodies throughout our lifetime.
Yeah. And I think, I like the word age. I like aging in reverse, but I agree with you. I think that the goal isn't to, God help me. Like when I was 20, I was a complete idiot. Like I do not want to go back to being 20. Like I'm happy where I like the wisdom and my lived experiences, I'm very happy where I am. But to your point around being optimized and optimizing the mitochondria, let's say through tools like fasting, which is a hormetic stressor. So my listeners know what this is. We talk about it all the time, but it's like a stress that's like, it's the Goldilocks stress, not too much, not too little, just enough. Right. And to your point, when we think about, and this is kind of bringing back David Sinclair's research in here, when we activate sirtuins, when we are fasting regularly, we can also upregulate NAD, right? And you talk about this in the book really beautifully, and such a like this is very complicated this is very complicated pathways, and you make it so accessible for people. But when we're fasting, as we age, naturally that NAD molecule starts to decline naturally with age. And I don't know about you, but when I learned about NAD in school, it was like this just like stupid throwaway molecule in the Krebs cycle. It wasn't really important. And what we've sort of come to understand now is that the more NAD you have, the better and the more efficient that Krebs cycle, which is the process by which we're creating the ATP, can happen. And fasting is one of the ways that we can augment, that we can improve the NAD production. Yes?
Yes.
Yes. Okay. Let's talk a little bit about AMPK. This is another, again, complicated science, but you do it so well. When we fast, Maybe first, just speak to AMPK in terms of like its role in the cell, right? When we have energy levels, I always look at it as kind of like the gauge on like the gas, right? It's like, do we have a lot of gas?
Exactly.
We're running out of gas, low in the tank. And then what happens, like what the role of AMPK is in the cell, and then how fasting can benefit that as well.
Yeah. And I mean, the irony is, I think I did a presentation like last year, and I was talking about car and the gas tank, talking about AMPK as really that, because sometimes talking about an analogy makes it more tangible. And so when we're really talking about these scientific principles and we're talking about the role within the cell, I kind of think of it also as like a spark plug. So when we have AMPK activation, I feel like I'm tongue-tied today. When we have activation of AMPK, we're going to generate more energy in the cell. We're going to have more energy to potentiate outside of the cell. And this can be diminished, depleted by our lifestyle choices. This can be diminished, depleted by the lack of autophagy or, the food choices that we make. So I always say that the lifestyle piece really plays a huge role in what is going on inside and outside the cell. And so the beautiful thing is that, when we really think about how efficient the body can be in this non-fed versus fed state, can upregulate, these key kind of principles so that we can optimize. I mean, that's really, use the word, but optimizing cellular energy to our advantage. And if we look at it like with that car analogy, like when AMPK is properly at the levels it should be at, we're going to feel very differently than people that are dealing with mitochondrial dysfunction that's at a level that where we're seeing with most metabolic diseases. I mean, certainly here in the United States, it's huge. And I'm sure most westernized countries, it's the same way. We just don't recognize it as such. I think we get so fixated on, as one example, we get so fixated on a diagnosis without really thinking about the downstream, like what's really at fault. What's really going on here.
And how did you get there? How did you get there? Like you didn't wake up with type 2 diabetes, or you didn't wake up with mitochondria, you didn't, or with metabolic syndrome. You didn't wake up with these things. This has been a slow snowball that has gained momentum over time. The Instagram thing is, or just the social media, I'm pointing out Instagram because it's more imagery than anything. It can be really damaging in terms of what we think is normal, because there's this assumption that, well, so-and-so and so-and-so and so-and-so with their hundreds of thousands and millions of followers are validating this way of eating or this way of fasting. But you do have to be mindful, particularly if you are kind of circling back to the muscle conversation. You want to build muscle. Muscles are hungry. You need to feed them to grow. And I have a program, like a glute building program. So I'm really, for rehab for back pain and also just to look good in a bikini. Let's just be honest. We want to have nice round glutes. And, I remember the first time I was talking to this group of women who had signed up. I was like, okay, so we're going to figure out what your caloric, maintenance level is. And then you're going to eat like 200 calories above that. I kid you not, Cynthia, like a third of them like almost fainted. They were like, what? I thought we were doing this to like lose weight. And I was like, yes, you can lose weight and build muscle, but it's so much harder to do it that way than it is to be in a build phase where you are in a caloric surplus and then move into a cut phase where you are in a caloric deficit, which is maybe a conversation for another time. But it is really, really important what you just said, because we do have women, I see women all the time that have been, it's entrained in us as women to like be as small as we can, right? To be as thin and tiny and, shrink, as much as we can. And I think that at least, part of the reason why this podcast exists and why I have guests like you on here is because I want women to get used to taking up more space. And it's okay to order your own meal. Like I saw this on Instagram the other day. It was like a menu from a restaurant, and it was, like burger, fries, salads, whatever. And then at the bottom, it was like, my girlfriend's not hungry was the menu item, right? And it was like $3, and then it got you like an extra patty and extra fries or whatever. And it's like, just eat, like be okay with eating. Strong girls eat food.
Well, and I think that's an important message, and one that I think many, many women, whatever messages they heard growing up or imagery that they heard, it's important that we eat, that we nourish our bodies. And I think, certainly programs like yours that are encouraging women to like not be so cognitively dissonant that they can't imagine like, okay, I have to trust the process. Like half of it is saying, I'm going to trust in the wisdom of Stephanie's experiences with this to know that this is what I need to be doing.
Yeah. Mental disorders, even with, diagnoses like depression, anxiety, OCD, ADHD, bipolar, autism, all of these seemingly unrelated, let's say, diagnoses seem to have a through line of metabolic dysfunction. And I thought we might start right there, right at the crux of it all. Can you discuss with us what are some of the unifying qualities between, a cluster of, I just named off, 5 or 6 labels that seemingly are very heterogeneous, they're very different in their presentation. How have you, what are some of the unifying qualities, let's say, between some of these mental illnesses?
It's a really important question. And of the diagnoses that you listed, I kind of want to take one of them out because it deserves its own category, and that's the diagnosis of autism. And the reason it deserves its own category is because autism is a neurodevelopmental disorder. And so for some people, it appears that that neurodevelopmental difference probably takes place either in utero or it takes place early in life, in the first several years of life. Something happens, but we have a tremendous amount of evidence to suggest that something happening is metabolic in nature. So metabolic dysfunction can cause that neurodevelopmental problem, but some of those changes can become permanent. And people are, autistic, have a difference in the way they relate to the world and their social skills kind of permanently. And some of those appear to be irreversible. And so I want to kind of take them and put them in their own bucket, and we can come back to that and discuss that specific diagnosis later. But the other diagnoses, this is just one of the many radical things about this theory and what I include in the book. And that is that even though we have all these different diagnostic labels like schizophrenia, bipolar, depression, anorexia nervosa, and alcoholism, on the surface, they're all different disorders. They have very different symptoms. They impact people's lives in very different ways, and they have very different treatments. And so on the surface, it makes sense. And that's why the American Psychiatric Association has DSM-5 and says these are all different disorders. But in fact, if you look at real people suffering from any of these disorders, it turns out the majority of people who get treatment in the mental health system today have more than one diagnosis. So for instance, a lot of people with anorexia also have depression or anxiety or OCD or a substance use disorder in addition to their anorexia. A lot of people with substance use disorders also have bipolar disorder or depression or anxiety or OCD. A lot of people with OCD also have substance use disorders and anxiety and depression. And you're kind of getting the theme. That when you look at real people with any of these disorders, the majority of people who are getting treatment, on average, in one study, they had 3.5 different diagnoses on average. More importantly, when we look at the risk factors of what causes all of these, the risk factors overlap significantly, whether it's stress, hormonal imbalances, trauma, neglect, substance use, poor sleep. All of those risk factors increase the risk for all of the mental disorders across the board, all of them. And the overarching theme, if you try to put it all together, right now, the mental health field says nobody can do it. It's too complex. It's just so complicated. The brain is so complicated, and all of these risk factors seem so different from each other. Nobody can make sense of it. But in fact, if you do a deep dive into the science, and in particular, a lot of cutting edge science on metabolism and mitochondria that has only emerged in the last 10 years or so, So this is brand new, cutting edge. Most people don't get it. Most people don't know it. But if you do a deep dive into that science, that actually helps us and allows us to connect all of the dots of all of the mental disorders. And the conclusion is what you outlined. Mental disorders are metabolic disorders of the brain.
So let's double click a little bit on mitochondrial health and what they do. I know a lot of people listening are going to say, "Oh yeah, I remember the mitochondria. Those are the battery packs of the cell. That's the Krebs cycle." That and then maybe we relive some trauma from high school bio with them together. But maybe we can do a little bit of a deeper dive, because one of the things I really appreciated about your book was that there was a stepwise and very clear explanation around some of the alternate, or I'll say additional, maybe is a better word, functions of the mitochondria. And I'd love specifically if you can touch on calcium regulation, and then we can talk about neurotransmitters and hormones. But the calcium piece is very, I think very, very important in terms, especially in the context of mental health and brain function. So talk to us a little bit about mitochondrial regulation of calcium, and then we can kind of parse that into a hormone and neurotransmitter conversation as well.
Absolutely. So as you suggest, calcium regulation is a really important function of mitochondria. More importantly, calcium regulation is a really important part of cell function. So when calcium levels are high, cells are kind of turned on, whether it's a neuron in your brain. When calcium levels are high, the neurons are actually active and they're firing. They're releasing hormones or neurotransmitters or whatever it is they do as a cell. But muscle cells, same deal. If you've got a muscle cell and the calcium levels are high, it means that muscle is actively contracting. It's working. It's putting in the work. When cells get turned off by these calcium levels coming down. So when the calcium levels come down, that kind of turns the system off and the cell goes into a resting state. So again, that could be a neuron or a muscle cell. And for a long time, it really wasn't understood what exactly is kind of taking the lead role in controlling these calcium levels. Researchers have known for decades that calcium levels were really an important signal, this on-off signal, but they didn't really fully understand what exactly is controlling the regulation of calcium. And it turns out, this is one of those cutting edge pieces of research that we've discovered over the last 10, 20 years, is that it turns out that mitochondria are instrumental in this. So mitochondria actually play a role in I'll just stop there and we can go into a lot more science. I don't want to get too nerdy, but mitochondria play a direct role in regulating calcium levels. So they can either provide energy to actively pump it out of cells. Sometimes they pump it into other parts of the cell, like the endoplasmic reticulum, for instance, which serves as like a storage site for this calcium to help turn the cell off. And sometimes the mitochondria actually take the calcium inside themselves. They serve as a little reservoir for calcium. And again, the big overarching picture is mitochondria are instrumental in affecting calcium levels, and that plays a direct role in whether cells get turned on or get turned off.
Yeah, and when we talk about I'd like to talk about some of the specific mental illnesses. One of the things that you highlight, let's say in bipolar disorder, is, when we talk about this hyperexcitability, again, if anyone's ever taken like neuroanatomy 101, or, we know that the depolarization of a neuron happens when calcium kind of rushes into the cell. And then that's where, and then we have this refractory period afterwards. And most of that is controlled, at least partially, by sodium. Calcium is in there as well. Can you explain rather, so we've talked about calcium regulation. How do mitochondria help with hormone production, which is going to be of extreme interest to the ladies that are listening, because we all talk about hormones on the show a lot, but also neurotransmitters as well, which whenever I talk about neurotransmitters, I will often explain them like hormones, but for the brain, right? I mean, I know that that's maybe an overly simplistic way of explaining it, but I think that people, like whenever I'm asked, like, what's the difference between those two? I think both hormones and neurotransmitters have profound impacts on our perception, on cognition, on behavior. So how do mitochondria, we'll start with neurotransmitters and we can move to hormones, but how do they, what is the direct role that they play, let's say, in either production of, and then which neurotransmitters are we talking about?
It's a really important question. And again, so the field of mental health has known, like, this is what the biological researchers have been pursuing, is like, what causes neurotransmitter imbalances? What causes hormonal imbalances? We know that cortisol is related. And this is, again, one of these cutting edge areas of research that we have only recently discovered how instrumental mitochondria are in both of these. So mitochondria actually play a very direct and powerful role in the production and the regulation and release of neurotransmitters. So the first part, in terms of producing neurotransmitters, mitochondria, being the powerhouses that they are, take things like glucose or fats, and they start breaking them down, and that creates energy. But as they break them down into these other molecules like pyruvate and other even smaller and smaller molecules. Some of these smaller molecules are actually instrumental in the production of neurotransmitters. And these include key neurotransmitters like serotonin and dopamine and norepinephrine and glutamate, which is actually, glutamate is kind of the neurotransmitter most people haven't heard of, but it's actually the most prominent neurotransmitter in the human brain. So it's like the big one, but most people don't even know what it is. So, so mitochondria play a direct role in providing building blocks. That's kind of an easy way to say it. To make a neurotransmitter, you need two things. You need building blocks and you need energy. And mitochondria are there to provide both of those things. So first, they make some of the building blocks that get used to put these neurotransmitters together, but then they provide the energy to regulate the whole process. And neurotransmitters end up getting bundled up into these little bubbles that we call vesicles. And then when the neuron gets turned on, it starts releasing these neurotransmitters, and mitochondria actually play an active role in that. And if you prevent mitochondria from like being at a synapse, for instance, the neurotransmitters actually don't get released. Even if the researchers squirt lots of ATP in, which is kind of the energy source, energy alone isn't enough. Mitochondria are somehow regulating the release of neurotransmitters. And the reason this is so important is because there's this thing called mitochondrial dysfunction, which in a nutshell means either a cell doesn't have enough mitochondria or the mitochondria in the cell are somehow defective or dysfunctional. They're not working right. And when a cell doesn't have enough mitochondria working in that cell, neurotransmitters can become imbalanced and dysregulated. And that directly can result in symptoms that we call mental illness symptoms. It could be, and they can be widespread. They can be things like having a panic attack for no reason or having anxiety for no reason. It could also be feeling depressed for no reason, all the way to having hallucinations or delusions. That when these neurotransmitter functions become imbalanced, all of those types of things can result.
This, in some ways, not always, but in some ways, this flies in the face of some of the traditionally held theories around mental illness. So in the book, you kind of detail a lot of them. The biopsychosocial model comes to mind, the monoamine hypothesis, let's say, of depression, where, the through line for why someone might be depressed is that they have some sort of chemical imbalance. So they're either, presynaptic or postsynaptic or, intersynaptic. There's not enough serotonin, let's say, uptake in the postsynaptic neuron, which is why the development of things like SSRIs and SNRIs are in the, we'll say, are in abundance in the way that they are, because this is sort of like the consensus in terms of why depression exists. But when we look at it from a slightly different lens, where we say maybe it's the mitochondrial efficiency and potentially dysfunction of, let's say, the neuron, or wherever, in whatever area of the brain, I think we can start to all of these different proposals for why mental illness happen start to make a lot more sense. And which is why, we started off the conversation saying, yeah, there's a lot of heterogeneity between something like depression and bipolar and OCD and anxiety. Like, they all present very differently. But when we kind of come down to it, it's either an overactivity, maybe via calcium regulation, via neurotransmitter, like the inhibitory neurotransmitters or the excitatory neurotransmitters that we talked about, or there's an absence, like there's an underactivity of the brain or an absence of specific functions in the brain. So I wanted maybe your comments on maybe your thoughts on how if at all, the biopsychosocial model, things like the monoamine hypothesis, which is still very largely accepted as the root cause for depression, how that bumps up against what we're talking about now, which is there's the mitochondria, which you might argue is the heart of, or the soul of, metabolism. When that goes awry, this is where we can see all these different disorders sort of play out in a different way.
Yeah, excellent point. So the brain energy theory actually doesn't replace the biopsychosocial model, and it doesn't really argue against a lot of those different assertions, although the chemical imbalance theory has actually kind of already been disproven. And some of your listeners may be aware of a study.
Well, we've had other psychiatrists on that have talked about this, so they're aware of it. But I think in practice, if you go to your medical doctor and you say, listen, I've been depressed, here's my 2 weeks, I've had a major depressive episode, can't sleep, all the things that, let's say, would qualify you for an MDD, you're probably going to walk out with some Zoloft or Wellbutrin or Prozac. Like, you're probably going to walk out with something like that. So in the clinical literature doesn't necessarily support that, but the practice is still very much at play.
Absolutely. And if you ask your doctor, why are you giving me a pill? Your doctor is very likely to still say, well, because you've got a chemical imbalance in your brain.
Correct.
And it's a serotonin imbalance. We know that. And that's why I'm giving you this medication that's going to increase your serotonin levels. And that's how it all works out. So again, that's largely been disproven. And if you ask just basic common sense questions about that theory easily falls apart within seconds. And so one of the obvious ways to disprove that theory is that we know that medications like Zoloft and Prozac actually increase serotonin levels in the brain within hours.
Right.
Within hours of taking them. Mm-hmm. And yet anybody who's taken them and benefited from them knows that it doesn't work right away. It doesn't work in an hour. You have to take it for several weeks before it really starts to work. And so right away,
if at all,
if it mm-hmm. even works. And unfortunately, if you look at longitudinal studies of all comers, all the people in the world who are taking SSRIs for depression, only about maybe 10% get a full and complete and lasting remission of their depressive symptoms. Only about 10%.
With the only intervention being the medication.
Yes.
Mm-hmm.
So looking to a pill to fix your chemical imbalance is not a very effective solution. And trust me, I know that some people might hear that as, Chris Palmer's being a quack, or Chris Palmer's,
telling me it's all in my head,
dissing the field. Well, I'm definitely not telling anyone it's all in their head, because I believe mental disorders are real disorders, and I see them torment people and really cause suffering and impairment. So I am not at all questioning the validity of mental disorders like depression, anxiety, schizophrenia, and others. They are real as far as I'm concerned. They ruin people's lives sometimes, and we need more effective treatments. But our current treatments fail to work for far too many people. And if you question that, or if you think I'm being too pessimistic, the hard fact is that mental disorders are now the leading cause of disability in the United States and throughout the world, the entire planet. More people are disabled from mental disorders. And guess what the diagnosis is? The number one diagnosis that disables more people on the planet is depression, plain old depression. And we have all these SSRIs and other antidepressants, and we've got talk therapy, and we've got shock therapy, and we've got all of these therapies, and they're not working for so many people. And we need a better way to understand these disorders and better ways to treat these disorders.
Your body has to have a way of determining, is it feast or famine? Do I have enough food, or do I need to start storing food because, boy, I might get into trouble? And this switch between AMP deaminase and AMP kinase is the determinant of that. When AMP kinase is active, hey, the body thinks the hunting is good. So it says, we don't need to store fat. We can burn fat, and we don't need to make sugar, make glucose, because the hunting is good. We've got plenty of fuel. And that's pretty much what we all want to keep active. We want to keep our AMP kinase active all the time. And one of the most potent ways of activating AMP kinase is to exercise. That's dramatically turns on. It's one of the reasons we exercise. It helps keep our blood sugars down. In fact, that's where the drug metformin used in diabetes works, because when you activate AMP kinase, you turn off a process called gluconeogenesis, meaning the new production of glucose in your body. That's shut off when AMP kinase is activated because we don't need it. The hunting is good. On the other hand, the other pathway is valuable too. We say we don't like that because we're making body fat and raising the blood sugar and blood pressure, all those things. But the reality is, take a step back, and in the context of history, powerful survival mechanism. But nowadays, we don't want to be activating a pathway in our bodies that's making body fat and locking it up so we have no access to it. We want to stay with AMP kinase. So the question is, what is the switch? What turns on AMP kinase or turns it off? And there are two very important processes. The first is the sense of the drop of the intracellular phosphate. It's the metabolism of fructose. Suddenly we're metabolizing fructose. That intracellular AMP is formed from ATP, that drop in the intracellular phosphate that says, hey, winter's coming, make it happen, shift to AMP deaminase, make fat, store fat, because you're going to need it if you're going to survive. Then the product of fructose metabolism is uric acid, and that does the same thing. So it's just in case it didn't happen to enough great extent, we're going to let the uric acid amplify that process even further, because the uric acid is this really fundamental alarm system. So we have two ways of really keeping that switch over to make fat, store fat, raise blood sugar, and raise blood pressure, just to be on the safe side. So we see a lot of that. Uric acid even feeds back to an enzyme called fructokinase. Fructokinase is that first enzyme in the metabolism of fructose that does what? Further consumes ATP, further locks us into this AMP deaminase part of the flow chart, and tells us that it's doing everything it can to allow us to survive in the times of food scarcity. So, unlike so many pathways in physiology that at the end of the pathway, it'll feed back to turn it off, right? That's how it works. For example, if our blood sugar shoots up, then we make insulin. Insulin helps us then to bring homeostasis into play and lowers our blood sugar. And then the insulin level has a homeostatic mechanism that lets it lower itself as well. But that's not the case here. This is what we call a feed-forward process, where once you started, it tends to amplify itself as a survival mechanism. So the story even becomes more complex when but exciting. I guess I'll get excited about this stuff. When we realize that it's not just the fructose we consume, but we can do things in our bodies to actually amplify our own production endogenously of fructose as a survival mechanism, such that even if we couldn't find fructose when we're hunting and gathering and turn on the mechanisms to make fat, we still have mechanisms whereby we can make fructose in our bodies and still then increase our uric acid, make more body fat, and survive. And that's pretty exciting, because some of the things that turn that process on, this so-called polyol pathway, converting glucose into fructose, are things that we do every day, like eating a lot of salt. Sitting down, eating a bag of salted chips to watch the playoffs, that raises our blood sodium level, and that turns on this polyol pathway that says, oh, we're dehydrated. Why would that make us think we're dehydrated? Because our sodium is going up. That's what happens when we get dehydrated. Well, our bodies sense that and turn on the production of fructose, because fructose can help us, when it's metabolized, make body fat. Well, what role does that have to play with respect to dehydration? Remember, body fat produces metabolic water. And that's why eating a salty meal increases our body fat, so that our bodies don't dehydrate as readily. We make metabolic water from body fat.
When it comes to exercise in general, be it resistance training or cardiovascular work, which are both important, by the way, I'm not poo-pooing anything. Why is it that we only focus on how many calories that we are burning? Like when we're on the elliptical machine, let's say, which always overestimate your calories. If anybody is like an elliptical queen or whatever, they always tell you you've burned 4,000 calories when maybe it's been like 300. Yeah. But why is it that we're always focusing on, well, I burned like 400 calories versus what you like to speak about, which is the hormesis, like the hormetics, like the adaptations that you're talking about?
Yeah, I don't think there was any nefarious motivator for this misinformation. I just think that we simplified everything and then made some logical conclusions in terms of what would be like how we should value exercise. So I'm going to take a step back. So obviously, obesity epidemic, we've been in it now for decades. This is actually a national security issue if you look at it from a economic standpoint, and it's a big deal, right? And so government, got involved. We need to help figure this out. People are obese and we're dying of these chronic diseases, and it's expensive to treat. And let's look at the science. And so on a very simplistic, I guess in a simplistic sense, and this is true, what I'm about to say is true. This isn't everything. It's way more complex than this, but what I'm about to say is true. In order to lose weight, you have to burn more calories than you take in. So no matter what, that has to happen for weight loss to occur. Now it's way more complex. What goes into that can be very complex. But at the end of the day, if I'm eating 3,000 calories, I'm only burning 2,000 calories. It's a law of physics. The extra 1,000 calories will get stored as body fat. It doesn't just evaporate, and vice versa. If I eat 2,000 calories, burn 3,000 calories, my body's going to tap into stored calories to make up the difference. So we understood that. So then what we did, and here's where we made the mistake, is we looked at exercise and we said, okay, got to burn more than we're taking in. So with diet, eat less. What about exercise? We're going to look at exercise and figure out how many calories we burn while we do it. And that's how we're going to value exercise. Okay. Whatever burns the most calories, that's the most valuable form of exercise. And that's what we should encourage people to do. Now, I can see the logic there. Now, here's the problem. The problem is it completely ignores the most important factor of exercise, the most important aspect of exercise, which is how it gets your body to adapt. And then what does that mean? That's the most important thing, because that's what sticks around. That's what makes the big difference. The calorie burn, okay, is actually the least important thing. That's that's all the way down the totem pole in terms of values of exercise. And I'm gonna talk about a study here to kind of illustrate what I'm talking about. There was a famous study done with modern hunter-gatherers, the Hadza tribe in northern Tanzania. Now they live the way we probably did 30,000 years ago. Okay, they're hunter-gatherers, so no modern agriculture, no modern technology. They gather and they hunt, and they're very active compared to the average Westerner. I mean, the way you hunt an animal is you wound it and then you run after it until it gets tired and it dies, and then you take it back. And so that's miles and miles and miles a day, and they walk for miles a day, and they're just very, very active people. And so scientists went down and said, okay, through some pretty sophisticated testing, they tested their metabolic rates. How many calories are they burning on a daily basis? And at the end of the study, they were pretty shocked to discover that the modern hunter-gatherer burns roughly the same amount of calories as the average Westerner, the average couch potato. Now, at first you think, how's that possible? They're moving all the time. They're chasing down animals. They're trying to find food. They're walking after to find water. They're not on watching TV and movies and driving in cars. Like, how is this even possible? Well, if you look a little deeper, it makes perfect sense if you consider human evolution, right? We evolved for most of human history as hunter-gatherers. If you look at the timeline of modern humans, 90-something% of the time that we've been on Earth, we were hunter-gatherers, and our bodies adapted to become efficient with calories, because it makes no sense for a hunter-gatherer's body to burn 10,000 calories a day. You can't find 10,000 calories in nature. We would have gone extinct. So the body adapted to burn less calories. And that kind of activity, the running, the walking, the constant moving, tells the body to become more efficient with calories. It's an adaptation process. Same thing that lots of running would do. Now, running has its own health benefits, but if that's all you do and you do lots of it, and on top of it, you cut your calories, what your body does is it learns to burn less calories. It learns to become more efficient. It does this through a couple different ways. The most obvious one being muscle pairing. It actually brings muscle down. And you'll see this in studies. You'll see that people who do lots of cardio with calorie restriction, let's say they lose 10 pounds, 5 of it will come from muscle. Now, the body's not burning muscle. It's paring muscle down. It's adapting. It's making its calorie burning engine smaller so that it can match the calories coming in. That's what your body's always trying to do. It's trying to match what's coming in. Now, there is a form of exercise that does the opposite. Strength training, resistance training, okay? Strength training and resistance training, although in an hour of, you could train like a bodybuilder for an hour, you're not going to burn nearly as many calories in that hour as you will going on a run or a bike ride. That doesn't matter. What matters is the adaptation. What strength training does is it tells the body, we need muscle, we need strength. The side effect of which being a less efficient metabolism, and metabolism that burns more calories. And so when you do something like that, you actually teach the body through adaptation to have a faster metabolism. Now, in modern societies, okay, now 50,000 years ago, you don't necessarily want a super hot, fast burning metabolism. That's a liability. I only can find 1,500 calories a day. I don't want a metabolism that burns 3,000 calories. But we live in modern societies where food is very, very easily accessible, hyper palatable, very convenient. We don't move much on top of it. Fast metabolism is an asset. Like if I could snap my fingers right now and boost everybody's natural metabolism by 50%, we would solve the obesity epidemic, right? We would see incredible progress in health. So strength training does that. It speeds up the metabolism. It's almost like, it's funny. I had a listener write in. They're an investor, and they said, when you talk about muscle and strength training, he's like, that's how I talk to people about money. And I said, what do you mean? He goes, well, you can try earning money, or you can take your money and then invest it so that it makes money for you. He goes, that's what it's like when you build muscle. It's burning calories for you. So, oh yeah, that's exactly what it's like. So we've been led down the wrong path to look at exercise as calorie burning and to completely ignore what those adaptations are. And then to take it even a step further, you brought up that a large percentage of your audience is women. Women have been lied to the most by the fitness industry. There's 2 reasons why. Women are the consumers. We know this. For most markets, women are the largest consumers, so they're going to get marketed to the most. And number 2, gyms had to figure out how to get women in their doors when historically they were places where guys hung out when they first started out, right? Like gyms were not friendly to women. It was just dudes. And what we knew about them was, the beach muscle movies of the 50s and 60s, these big dumb bodybuilders. And then, then you had Pumping Iron. And
I was going to say Pumping Iron. Yeah.
Yeah.
Mm-hmm.
And so women are like, yeah, I'm not going to look like, I'm not trying to look like that. And it doesn't seem like a very friendly place. And so what gyms did is they, created words like toned, which, that word existed before, but not the way the fitness industry used it. They say, you're going to tone muscle, which is, you don't tone your muscle, you build them.
This gives me like, I get a little twitch when I hear that word, because this is not the way that we describe like muscle. Either you have, when we talk about tone, you're actually commenting on the neurological health. Yes. So you either can be hypertonic, hypotonic. That's tone. It's tone of the nervous system, usually the peripheral nervous system, but it can also be axial as well. It can also be central. I hate this word toned when we talk about women, but like in terms of communicating to, anytime I've ever tried to say, well, that's actually a way that you describe nerves, people are like, what? That's not what I mean. I want to look like the girl on, Shape magazine or whatever, or Oxygen or whatever it is.
Yeah, because building muscle sounds like, oh, I don't want to look like Arnold Schwarzenegger, right? So they created this word tone. Hey, ladies, come to our gym. Don't lift heavy. Do 5,000 reps with 2-pound dumbbells and do all of our classes and get on the treadmill, and you'll build toned, lean muscle or long, lean muscle, which that annoys me too because
long. Yeah.
You can't make your muscles longer. I hate to tell you.
You can't do that.
Attachments are the way, unless you surgically remove. And I don't recommend you do that. So, but so they did this, right? And I remember as a trainer, by the way, when I first became a trainer, I was a kid. I was 1997, and I walked into the gym that I worked out at, and I finally turned 18. I was old enough to be a trainer. I applied, I got hired, and I remember going into the women's area for the first time, because they had a women's area with machines. And I remember even then as a kid thinking how ridiculous. It was the same machines that they had in the regular workout floor. The difference was the upholstery on it was pink. That was the difference. And the dumbbells only went up to 10 pounds and they were also pink. And I remember even thinking then, how condescending, like you just make it pink and now it's for women. And I remember even thinking then, like, man, they lie. They really do lie.
Yeah.
And they do it quite effectively. No, women should not be afraid of lifting weights. You're not going to build huge, massive muscles. What you will do is speed up your metabolism. And through the process, here's my favorite part. And I love communicating this. When you send signals to your body to adapt, and your body and everything is working and it's adapting in whatever way you're telling it to, it organizes its hormones in a way to do so. So what do I mean by that? If I tell my body to build muscle and I feed my body appropriately, so it's got the building blocks to build the muscle, and I'm not under too much stress, and I'm getting good sleep, so everything's good. As a man, what my body will do is say, okay, we're ready to build muscle. What hormones build muscle? Testosterone. What other hormones can help? Growth hormone. What else? Let's become more sensitive to insulin, right? In women, you see a balance of estrogen and progesterone. You see cortisol balance, right? Happening better, because high cortisol, not very good for muscle, right? Low cortisol, low energy. You get this nice balance, right? So your hormones actually, because everybody's trying to get this youthful hormone profile. How do I get my youthful hormones, right? Well, here's what you do. One of the easiest ways to do it is get your body to build muscle, because all the hormones that do that and all those hormone profiles that do that are the youthful ones that go into building muscle, and you end up feeling that way. You end up feeling better. Now, on the flip side, I talked earlier about how just tons and tons and tons of cardio plus calorie restriction will cause the body to pare muscle down. Your body will also do that in the opposite direction. If I tell my body to pare muscle down, it's going to organize its hormones to do so. In men, lower testosterone. And you see this in studies. In women, higher cortisol, imbalance of estrogen and progesterone, right? You start to see the hormones organize themselves in that way. By the way, when your body's trying to become more efficient with calories, it also starts to learn how to store body fat better. It actually starts to become a better fat storage machine. So if you train the wrong way or you use the wrong approach, what you'll actually end up doing is this. And I'm about to illustrate what probably 99% of your audience has probably felt before, right? You're ready to lose 30 pounds. You jump on the treadmill, you cut your calories, lost 10 pounds real fast. Oops, I plateaued. Okay, now what do? I know. More cardio, less calories. Oh, lost another 10 pounds, plateaued again. What do I do now? Oh, can I do more cardio? All right, I think I can. Can I cut my calories more? I think I could get down to 1,000 calories. Oh, now I'm down to 30 pounds weight loss. I'm eating 1,000 calories a day and I'm running 6 days a week. I can't maintain this. This is crazy.
And I'm miserable.
And it sucks, right?
Yeah.
Now, if you do it the other way, like I'm talking about, if you fuel your body properly, do some strength training, the weight loss is a little slower. And part of that's because you may be losing some fat, but you also may be building some muscle. By the way, if everybody watching this lost 10 pounds of body fat and replaced it with 10 pounds of muscle, they would be smaller. Muscle is I think it takes up something like a quarter less space than body fat does. So you'd lose a quarter size, right? And you'd weigh the same, right? But if you did it the right way, you would notice that your fat loss snowballs. And this is a very realistic thing. I've had this happen quite a few times with clients. At the end of your weight loss journey, you're eating more than you did when you walked into it. And now you can maintain that. Like how much easier is that to maintain, right? It's a lot easier.
I get a lot of fasting questions, and I wanted to maybe spend some time on all the fasting stuff that came in. So there was this one question that came in. It was like, is constant low blood glucose levels optimal? And this kind of goes back to what you were saying before about like, we love to live in the extremes, right?
Yep.
It's like, we love to be like, well, my blood glucose, yours is 70. Well, mine's 0, it's like, well, I'm going to one up you.
My blood glucose is better than yours.
Yeah. I can one up you by getting it even lower. And I think that, the better way to think about optimizing glucose regulation is what is the response of the body to an external or internal stimulus, right? So what is the response of the body to glucose as an exogenous substrate? So you have a carbohydrate meal, or you have a protein meal, or you just have a meal, okay? What does your body do? So if you have a 70, in her question, she's like, is like 70 to 89 milligrams per deciliter good, or should it be even lower? And it's like, okay, so there's a lot of reasons why even just looking at that number is incomplete. So you could go to you could have a CGM, or you could go to a lab and you could get your blood drawn. Let's say it's fasted, and you might have rebound hypoglycemia, which you're going to have super low glucose, right? Oh, you're going to be in that range or lower. And they're going to say, hey, good job. You got like that really low blood glucose. But of course we know that there's a process that's behind that's sort of artificially creating this low blood glucose. On the opposite side of that, you could have, we talked about this on the last show, the dawn effect, right? You could have this glycogenolysis and gluconeogenesis that sort of spills blood glucose into the blood is what I'm trying to say. And that's going to artificially raise your blood glucose. So does that mean that individual now has deranged blood glucose regulation?
Yeah.
Maybe not, right? So we want to look at things in context. And then just one other thing I wanted to talk about, and I'm talking specifically to this woman and every single woman who always wants the A+, okay? You want to look at your response. So if you have food, and let's say within 2 hours, maybe you started off at 70 milligrams per deciliter, as she gave in her example. And then, I don't know, you go up to like 130. And then within 2 hours, you're kind of back down to like 100 or 90 or 80 or whatever. I think that that's a good blood glucose response because we're looking at it in context.
Yep.
If, however, you start off at 70, you have a meal, and then your blood glucose goes to like 140, 150, 160, and then it stays there, that's the bigger problem.
Yes.
Right?
Yeah.
Yeah.
Agreed.
So I just want her and everybody who's listening, it's like, we're not always striving for one number. And I just interviewed Dr. Bret Scher, from the Diet Doctor. And he was saying, I have a patient, I can't get his insulin under 15. but he's so healthy. He's like the healthiest he's ever been. And that's where we're going to stay with him. Right. But if we said arbitrarily, because I was like, oh, well, and I do this too. So like to this woman who asked this question, like, I'm with you, because even in that interview, when you hear it, and I'm calling myself out here publicly, I was like, well, ideal insulin should be between 5 and 7. And he was like, okay, also, let me school you for a minute. And I have a patient who is an outlier to that example, but they're also experiencing the absolute best health that they ever have. And their insulin is hovering around 15. Now we've gotten it down from, whatever number it was, 40 or 30 or whatever it was before. So there's been a marked improvement in their insulin output, but it's still not kind of fitting in that little box that I have created where I'm like optimal 5 to 7, So we want to be thinking about like relaxing our thinking a little bit. And I have to do this, and I have to work on this as well as a practitioner, because there's like optimal ranges that I have like, become my mantra that I'm always trying to push my patients towards. Right. But sometimes that's not possible.
Yeah. Yeah. There's so much in that. It was that I think we can educate on. And here's what I look at it, blood sugar, from a very simplistic, metabolically flexible place, which is we go back to, we're either a sugar burner in a sugar burner state or a fat burner state. So when your blood sugar is lower, so when you're at like 80, and you're now maybe 10 hours into a fast, your ability to switch over into the fat burner place is going to be much more effortless, because your blood sugar doesn't have as far to come down to signal to the body it needs to switch over into fat burning to make ketones. Now, I have watched a lot of women who will tell me, my blood sugar is 70. I've been fasting 20 hours. I can't get a single ketone to come out of my body.
Yeah.
And in that scenario, we got to start looking at toxins, because toxins are causing really affect if we can go sugar burner, fat burner, and how metabolically flexible we are. So if I'm the woman who asked the question, if I'm always just trying to keep my blood sugar between 70 and 90, that's only one part of the story. The next part of the story is, are you making ketones? How can you make ketones? So make sure you can do that as well. The last thing that I want to say on this that's really important, well, 2 other things I would say, is what you talked about, which is the post-meal blood sugar. I think we don't give that measurement enough credit. So if you want to know if you're insulin sensitive, here's a really good question. Does your blood sugar come back to a pre-meal level, what it was before you put that food in your mouth? Does it come back within an hour to 2 hours after that meal? I think clinically they say 2 hours. I personally like to see somewhere between an hour to 2 hours. And if that you're coming back into a pre-glucose meal number that was similar, then your body's pretty insulin sensitive, which is what we're looking for. And then the last thing, I recently had a really cool conversation with Dr. Boz. If you haven't brought her on your podcast, you need to bring her on.
Oh, you got to make an introduction. I don't know who that is.
Yeah, she's another YouTuber that has been talking. She's an internist that has been talking specifically about hemoglobin A1C. And then she has something called the Boz ratio where you can measure autophagy. But here's what she told me recently is that if your hemoglobin A1C is above 5, then your red blood cells are going to be gucked up with glucose, and you're not going to drive oxygen into your tissues. So I say that to say blood sugar is one number, and I really want to compliment the woman who asked this, that she knows it. She knows 70 to 90. Now, the next question is, can you get into ketosis? What does your blood sugar do after you eat? And what's your hemoglobin A1C at? I think that's the next elevation of that conversation.
Beautiful. All right. So, Mindy, this is a question. Do you fast every day?
I would say 95% of the days. I really try to make myself eat breakfast one day a week. I don't crave it, but I'm really trying to mimic more in and out of feast famine cycling. I think a better question would be, do I fast the same way every day? And the answer is no. Sometimes I maybe it's 10 hours, 12 hours. And other days it's like, I'm just going to go all day and I'll have one
Yeah.
meal. You know, recently I decided I got really into doing 3-day water fast. So I've been trying that out and seeing where that sits with my hormones. So I'm always varying it. The hardest thing is to like an 8-hour window would be really hard for me to eat within an 8 hours.
You mean fast? So fast for 16 and eat for 8 hours? That's the hardest one for you?
No, like, I'm sorry, fast window of 8 hours. So like, I would
eat for 16?
Yes.
Wow, that's hard. Yeah. I would say that.
But that's what most people are doing, right?
Yeah. Yeah.
So you would never see me like finish dinner at 8 and then wake up in the morning and eat again at 8. Like just wouldn't happen. Right. So I guess I'm doing some form of intermittent fasting almost every day.
Yeah.
What about you?
Yeah, I am too. For me, I'm still cycling. So I typically find in my follicular phase, I can do a little longer, so I will push it a little more. So I like, a 10, like I'll fast for 14 hours, maybe 16. And then, my window is, whatever the either 10 or 8 hours. Eating window. In my luteal phase, I don't feel like doing that. So I'm just generally hungrier. And I would also, so I'll do like maybe a 12-12, 10-14 also works well there for me as well. And I think that it also depends for me on my output. So my physical activity, if I have had a monster leg day, I'm just generally hungrier. So no matter kind of where I am in my cycle, I will probably be a bit more lenient in the hours that I'm fasting. So I also kind of take into account my own, we'll call it auto regulation, like how hungry I am, because usually like my legs are hungry because I really push. I really push legs. So I'm usually a little bit more lax on leg days for my fasting window.
And I would say I do that in an opposite way when I know that like I have a bunch of podcast interviews, or when I was writing the book, like when I know it's a performance day, as far as my mind goes, I will actually fast longer because I know with ketones, I can just get to that, to your point, to those neurons can fire up and give me some words a little bit better if I'm in a state of ketosis. So
what about hair loss and fasting? This was a question that came in. Do you see this with your women with fasting, if they're doing it a certain way, a certain type of fast, a certain length? Is that something common that you see?
Yeah, 1,000%. And it means two things. It means you're fasting too much. Or you're not fasting with your cycle. You're not stepping out of a fasted state that week before. You're not doing enough variation. And then the third thing I would actually throw in there is minerals. A lot. We're just so depleted in
Good
minerals.
Point. Yeah.
I feel like fasting's like a mirror. So if you look at something like my hair is falling out, the next question would be, am I using the tool right? Which is why variation's really important. But then the next one would be, what am I deficient in? What am I depleted in? And we all are so depleted in minerals right now because of the way our soils are.
What are some of the, if someone has never fasted, like I have a 45-year-old woman who's listening to the show now, she's never fasted before. What might be some of the first couple of steps that you might counsel her on to increase her fasting tolerance? And then how might she prepare for a successful fast? And then I guess my second question when you're done answering that is, then how do you break the fast?
Yeah. So I would say first and foremost, if you're standard American diet, couch potato, and this is really your first foray, we have to stop snacking. So the whole methodology of snacking in between meals, snacking after dinner has to end because that will force you to restructure your macros. So when you sit down for your first meal, you're going to be protein focused, non-starchy vegetables, fats if you need them. Like if you have a ribeye, you've already got the fats in it. But if you have a filet, and I'm just using this as an example because I've used it quite a bit today, that's really the methodology. So higher protein, non-starchy vegetables, that's a good starting place for most people. And I find that we really look at it as we're going to fast from dinner to breakfast. That's a starting point. That might be 14 hours, but most of that time you will be spent sleeping. And that can be very challenging, especially if you go home from work and you have some sweets after dinner and then you have alcohol and all of a sudden that goes away. That is a major shift. So really starting from that 14 hours. And if you're 45 years old, still getting your menstrual cycle, this is something you would start at the beginning of your menstrual cycle. This would not be Don't do this the week before your menstrual cycle. You will set yourself up for a
You'll
disaster.
hate it.
Yeah,
You'll
you'll be
hate
very
it.
unhappy.
Yeah.
So really what you're aiming for is for that first 2 weeks of your menstrual cycle, you might go 14 hours one day. And if you're feeling pretty good a couple days later, you can go to 14 and a half, then to 15. I find that it really depends on how carbohydrate dependent someone is, how quickly we can get them to being much more fat adapted, where they can flex between utilizing ketones and glucose for fuel. And so for some people that could be 2 weeks, for others it might take a bit longer, and that's okay. Like, each one of us are individuals. I think the most important thing about honoring our bodies is that when we are in a fasted state, I'm a fan of a clean fast. So I'm really looking at bitter tea. So black tea, green tea, it's meant to be bitter. Plain coffee. You can add salt, which will change the profile, but it's not going to break a fast. Or even there's good research to show that cinnamon can change the flavor profile enough, make it less bitter, will help with insulin sensitivity, or water.
Do you like dandelion tea? That's my favorite. Do you like dandelion tea, or is that?
I do. It's funny how I've kind of have gotten.
It's like the throwaway plant. Everyone's like, ugh, weed. I'm like, I love dandelions.
Well, and it's like, now I drink so much bitter tea that I don't want to taste anything so I've now become a little bit of a tea connoisseur, just because I've tried so many teas to kind of get a sense for which one has higher polyphenol content, which has a lot of beneficial compounds in a fasted state. So when you're getting ready to break a fast, when you aren't feeling like you want to eat everything and anything, because sometimes people fast too long and then their amygdala overrides the prefrontal cortex and they want to eat everything, that's a sign you need to break your fast. But if you're getting ready to break a fast, some people, it's a little bit of experimentation. Some people want to break it with bone broth. Some people want to have a light salad. Maybe they're not ready for a bigger meal. Always with protein. Fasting is always broken with protein and either some healthy fats or protein and a high quality carbohydrate. I think it depends on where you are in time and space. On days I lift, I am much more cognizant of getting in some healthy carbs, small amounts, because I'm at a stage where I don't need a lot, but really being cognizant of what I'm eating, but always protein, non-starchy vegetables, because that's going to help with fiber, phytonutrients, et cetera. And then adding in fats if they're not already there and being cognizant of those. I know you're a fan of this as well. And then the carbohydrates, it really depends. Like, I'm more squash, sweet potato, root vegetables, low glycemic berries, a tart apple, maybe some citrus fruits. That's where most of my carbohydrates kind of reside, because I'm gluten, grains, and dairy free. It really depends on what works for you. I find people need to experiment with, do they need a smaller meal when they break their fast with the expectation that they're going to maybe have a larger meal in an hour? Or can they sit down and have a big meal, like 40, 50 grams of protein, be satiated, walk away, and then not eat again for 4 or 5 hours? So I always say, like, do a little bit of experimentation. And this sometimes freaks people out because they like to be told what to do as opposed to experimentation, because that's a little scarier.
You got to play.
Right.
You got to play, because what's going to work for Cynthia is may or may not work for me, may not work for you. And that's kind of the play. That's sort of the joy piece as well, because we have to be okay with playing and then okay with being a beginner. It's okay to fail, right? It's okay as long as you learn from what didn't work.
Yep. And I think it's really important, especially if you're still cycling, to really know where you are in your cycle. Yeah. I get DMs from doctor friends all the time, and they're like freaked out. Why can't I fast? Like, I barely made it to 14 hours. So I'm like, where are you in your cycle? Oh, I'm going to get my period in 2 days. I'm like,
that's fine.
Yeah, go ahead and eat. But I'm like, you need to lean into your physiology. Now, the beauty of not being at peak fertile years or not being in perimenopause, being in menopause, is that women have a lot more flexibility. You still have that lifestyle piece that's critically important, but you don't have as much fluctuation in your sex hormones. And so women oftentimes, this is the only time I will say this, can act more like a guy in that they don't have as much restriction because there's not as much hormonal flux. With that being said, they still have to sleep well. They still have to lean into their exercise. They still have to eat the anti-inflammatory nutrition. They still have to manage and mitigate their stress. That doesn't go away, but it makes you certainly feel like you have a bit more flexibility in what you can do, when you can fast, how long you fast. Like, my husband and I could fast the same way if we chose to, just based on the fact of where I am. But with that being said, it's really just honoring where you are in time and space. I know that when I don't get good sleep, I won't fast as long. And so this is important. Like, I know when I'm traveling, sometimes I'll fast longer because I'm in an airport or I'm in an environment where I can't eat the way I want to. Just acknowledging that depending on where we are in our cycles, where we are in our lifestyle, if we're traveling, et cetera, you can adjust those variables to work to your advantage. In fact, I think that now that fasting is such a large part of our lifestyle, to me, it's so much, I have to worry about a whole lot less, like less food prep, less meal prep, less cooking. I see it as a win-win on so many levels.
It's like, who wants to cook? No one. Great. We'll fast.
Exactly. It's like, that's what I'm doing today.
Yeah. So what is when you are in your environment, so when you're in your home and you have your natural sort of routines, what does your fasting regimen look like?
My body, so I do really well with a fasting window between 10 and 6, 10 and 5. That's just where my body naturally, like, if I get, because I work out early, kids get on the bus, I start working. 10, 11 o'clock is when I typically will break a fast. I will break it with a real meal. It's my biggest meal of the day is what I break my fast with. And then I will usually shut my feeding window. This has been the benefit of the pandemic, as I realized my body actually doesn't want to eat at 7 o'clock at night. It wants to eat earlier. And so I can lean into that. My kids are very accepting of the fact that I will sit down with them at dinner time, but I may not be eating at 7 or 8 o'clock at night, but they're teenagers and they're very athletic. And that's just worked well for me. I definitely have days where I can feel I need more food. And so when I feel that way, I don't deprive myself. I try to really just say, if I'm hungry enough to eat protein, then I'm hungry. And so that's kind of my barometer that I use to, get a sense for whether or not I'm craving crap or am I craving real food. And I think that it's important for people to understand that this is what my schedule looks like most days: 2 meals in a 7 or 8 hour feeding window. Some days, if it's really busy, today's a good example, I'm breaking my fast later than I normally would, and that's okay. And I will probably close my feeding window at my normal time. So I may get 2 meals in a more compressed time frame. And that's just what I've found has worked really well for me. For me personally, because of where I am life stage wise, my Oura ring, my glucometer, my continuous glucose monitor, my data supports me eating earlier in the day. Like, that is much more aligned. And I tell people, if you look at circadian biology, if you look at the research that's done on, the suprachiasmatic nucleus and the melatonin secretion, melatonin clocks, it really supports eating during the daytime and not eating at nighttime. But that's not to suggest that never happens. I celebrated Valentine's Day with my husband a couple of days ago, and we went out, ate later than I normally did. My Oura ring and everything else told me that was, did not love that I did all those things. But with that being said, that's the beauty, is that you can adjust as you need to.
I love that. Well said. I too have found, when I first started fasting many, many years ago, first started writing about it, I was doing the breaking the fast at noon, and then, an 8 hour eating window. I was cutting it off at about 8. And I found with time, waiting until 12 was really difficult for me, especially if I was working out in the morning. So I would lift and then not eat anything after, and then wait until 12. And I was like, man. So I started slowly there's been a phase, like a shift in time for me, very similar to you, where I will typically finish my workout, let's say somewhere around 7. And I will actually start eating, I'm making breakfast with the boys. I usually have like a protein shake and some carbohydrates. So I'll start eating around there, and I stop around 4, like 3 or 4. So I'm very, I did like 10 to 6 for a little bit. And then I've been in at least in the past year, I've been in a bit of a build phase for, with my muscle program or fitness programming. So I found that I've needed to shift that food earlier in the day. And when I finish I sort of laugh about it. I'm like, I feel like my grandmother, like going to the restaurant and getting like the seniors discount because I'm eating at 4 in the afternoon. But I feel so much better doing that.
Yeah. I'm the same way. And it's funny, my 16-year-old was making fun of us because we made dinner reservations early on Friday night. Yeah. He's like, what are you guys, like the grandparents? And I just looked at him and I said, I'm not even going to explain to you the physiology behind why I do that. And he was just like, ugh, it's so embarrassing. Look at my mother. But I said, we came home and it was like, we got home and it was like 8:30 at night. And my husband and I got to, hang out together and watch a movie with our kids. And they thought they got a pizza. They didn't care. They were just happy they got fed. But yeah, to me, the older I get, the more I lean into what my body needs. And so last night I was in bed at 9:00 at night, like out, totally out. My husband's like, I came home from carpooling with, lacrosse and swim team. And he's like, you were in bed. And he's like, I don't think you said anything. I think you were asleep. I said, well, I need some nights like that. There are certain days where I'm like, I cannot talk again. I cannot do more work. My kids are all situated. My husband's situated. The dogs are situated. Now I need to just honor what my body's telling me. It's like, I'm going to soak in magnesium and I'm going to go to bed.
Those are some good boundaries, my friend. Love it. Love it. We're going to talk about veganism, but I also want to talk about how we got here, because it seems like there is a very strong push for things like saturated fat. Well, we talk about this, and we can talk about Ansel Keys perhaps as well. I want to talk a little bit about bad science, like how we got here. And there's sort of these persistent myths. Saturated fat is bad. Salt is bad. Meat is, I remember, I think it was the WHO classified, I think it was bacon as like a class 1 carcinogen. Yeah. Class 2, thank you. Class 2 carcinogen. How do we get here? Is there manipulation of data? Are there external interests that have played into these narratives? And maybe Ansel Keys is a good place to start. Maybe you want to go back before that.
You go a little further back. It's such a long story that there's so much to this. And I really do think there are big factors that have shaped how we think about food, because I don't see how it would be possible if there weren't big driving influences with a certain agenda. Because without those big driving influences, we would have just done what humans have always done. Even up until the 50s and 60s, we have a pot roast for dinner and we have vegetables and whatever else on the side, and we were healthy. It's like, of course, like this was our trajectory for all of history. And so the reason why I know there was influence is how did that change and why did that change, especially knowing the science of that animal foods have superior bioavailable and complete nutrition. The only way that we could have gone off our path for millions of years of always striving, all the cultures around the world, always striving for animal foods, more animal nutrition. Even now in developing countries, they are always in search of more animal nutrition. This is what I saw in Africa. This is what you see in China, anywhere. They want always more. I'm working in the field so that I can afford meat for my family. And so what changed? That's such a good question. What changed? Why would we all of a sudden deviate from this path of inherently knowing without even science? Back in the day, we didn't have formal science. We knew the importance of animal foods. So that tells me there must have been some intervention, some sort of different thing going on. So where it started, I looked in, when did we start thinking meat was bad? Because we thought it was good for all of history. And it started with Seventh-day Adventists, and it was sort of this religious thing. And so it goes back to Ellen G. White. There's a whole story here. I can't get into all the details, but it involves John Harvey Kellogg. And
Kellogg was something I wanted to talk about as well. Let's talk about him.
Okay, John Harvey Kellogg. So he was a product of these Seventh-day Adventists, and he was actually like a protege of Ellen G. White, who was kind of the founder of the Seventh-day Adventist religion. She had these visions.
Which is one of the blue zones, if I'm not correct, right?
Yes. Later, Loma Linda is one of the blue zones, which is in California, which is a Seventh-day Adventist area. So yes, ultimately it became a quote blue zone. But how it started was that she had this vision. She had these visions that meat caused men to be angry and violent, and that we need to go back to a Garden of Eden diet, which is in the Bible was supposedly fruits and vegetables and without meat. And this is a time when, men were drunk and beating women, and women didn't have all these rights, and it was a bad time. And there's also unscientific. This was in the late 1800s. So they didn't really know what was going on. And so they blamed it on meat, and that was her idea. And that's kind of what this whole Seventh-day Adventist religion was based on. So John Harvey Kellogg was indoctrinated as a young boy in all this stuff. And he went on to make all the breakfast cereals, and even had this thing called the sanitarium where he'd try to heal people. One thing's being masturbation. He thought that eating very bland foods like these unsweetened, like oat and like grain and cornflake type cereals, that would help make you pure and not have sexual desires. And part of going to the sanitarium was this cleanse of like, you're going to go here and cleanse yourself of your sins and your sexual desires. And
part of which, if I may add, was for women when they were trying to, when he was trying to help women stop masturbating, was to put carbolic acid directly onto that female's clitoris with the idea of trying to move her away from sexual pleasure, because of course there's acid on her genitals now. So how is that ever going to feel good? So please continue. I just want to make it's horrendous. It's a crazy time. Philosophical premise is abhorrent and would absolutely never. I mean, these people will be locked away. Hopefully they would be locked away. In
modern times. But this was in the early 1900s, and people didn't know better. And they had all kinds of wacky stuff going on back then. Mm-hmm. And man, so that's a whole side story. There's all these big cereal companies that popped up. This was also Battle Creek, Michigan, in this area. And ever since then, actually, the Seventh-day Adventists have had major influence on the world and nutrition. And they actually fund a lot of the nutrition studies. They put out many textbooks. They have many radio shows and programs, especially in Australia too. There's this Dietetics Institute, whatever it's called, in Australia and some of these other countries. It's all Seventh-day Adventists. They have huge money and huge influence. And this is what's perpetuating a lot of these myths around nutrition. And they put out pamphlets, and if you go online in Australia to, in your doctor system, whatever it's called, the EHR, the health record system, mm-hmm. they control what's being sent out to these doctors to like interventions for certain things like heart disease. Oh, low saturated fat. You need to eat plenty of cereals and whole grain. All this stuff is dictated by this Dietetics Association that's really a Seventh-day Adventist association. So that's a whole rabbit hole. Dr. Gary Fettke and his wife, Belinda, actually do a lot of work on that. If people want to look that up, it's Gary and Belinda Fettke, Fettke. I interviewed them both for the film, and they put out great content, do podcasts on this and all that type of stuff. So go there for more information. But then, so that was in the early 1900s. Then it kind of goes on to the Ansel Keys stuff. It seems like every decade there's more of this anti-meat kind of messaging that happens. And in the 50s is when it first started with Ansel Keys, and President Eisenhower had a heart attack. And so this was a big thing, like, oh man, heart disease wasn't really a problem before. But you know what else was going around at this time in the 1950s? People were smoking in elevators. They're smoking in cars. They got their baby in the backseat. They're smoking cigarettes. The whole car is filled with, everyone's smoking. And we also got all these new things like margarine, Crisco, all the new vegetable oil.
But 3 out of 4 doctors recommend Camel.
Doctors recommend cigarettes, and they recommend fake processed oils instead of butter. Can't believe it's not butter, Crisco, all this stuff. This came about in this time period. They first invented Procter & Gamble 1914, 1917, 1912, somewhere around there. And they started rolling out in a big way, 50s, 60s, all these advertising campaigns. So it's 40s even. So it's no wonder we started having heart disease. We had more people smoking. It was insane smoking, insane amount of these processed oils and trans fats, and more processed foods too, right? This was the beginning of TV dinners and all this type of stuff. So there's another guy named, I just forgot his name. He was in England. So he's a British guy, that John Yudkin, who had an opposite idea. He's like, what about if it's all the sugar and flour and oil that came into the culture's diet? Because he was looking at all the British colonies, and everywhere he'd see around the world, India and South Africa and all these different places, when they had these 3 things, the sugar, flour, oil, move in, they got disease. So he's like, I don't think it's saturated fat, buddy. We've been eating saturated fat forever. What if it's these 3 new ingredients that seem to, whenever they come into a society and they get modernized and they get trade and they start, trading their natural foods for sacks of sugar and flour and buckets of oil, then they get sick. Wouldn't that make more sense? And Ansel Keys, he was a domineering personality. He basically won this sort of debate, and famously used 7 countries epidemiology. He looked at 22 countries actually, and he looked at how much saturated fat they ate and the cholesterol and their heart disease. So he threw out all the ones that didn't fit, but chose the 7 that did. And so then he had this nice little line. It's like, oh, see, the more saturated fat they eat, the more heart disease. And everyone in the US was like, okay, let's go with this. And you can get more into like motivations and why they chose that because all the big companies that, and all these lobbyists that were even around back then were making all the money off the foods with the sugar, the refined grains, and the vegetable oils in them. So I don't think it's great if we blame it on them. We could blame it on meat, where meat is, an expensive thing that a lot of people don't make a lot of money on, right? There's not like big brands of meat that people can make a lot of money off of. There's not a big profit margin in whole foods. So really, I think it's a lot of the story is about the lobbyists and the money and the advertising and the who can fund the studies of who has the profit. And the profit has always been in the processing. That's one of my little taglines. The profit's in the processing. You can get like 10 cents worth of ingredients and make it into Lucky Charms, and you can sell it for $5 a box. You're trying to sell eggs. I have my company nose to tail. I try to sell meat to people. There's no profit margin, right? You try to sell eggs. It's like, okay, it took me $3 worth of labor and time to grow these eggs, and now I can sell it for $3.50.
And the facility and the nurturing of the chicken.
Everything about it.
Yeah.
Feeding caring from them. So it's like, okay, it cost me $3 to make these eggs, and I can sell them for $3.50. And then we got Lucky Charms. It takes 10 cents of subsidized corn wheat and oil and whatnot to make it, and you sell it for $5. Everyone knows where the profit is. I hope everyone's seen these diagrams of all the food companies that own everything. These webs of Kraft, Heinz, just every single company you've ever heard of is owned by all these big companies that just make all the processed foods and make all the money. Right? It's not like there's, oh man, the guy who makes eggs, that guy's a trillionaire. No one. There's
right.
This is not how it works.
Yeah.
So you can follow the story from there. It's really a story about money. And
there's the Rockefellers in there as well. With the
oh my
fuel
God, Rockefeller. Yeah, Rockefeller medicine. You can look that up online. There's a little documentary about Rockefeller medicine and just how they've kind of dictated how the medical system works. And basically any natural doctors or natural homeopaths or, anything they used to be called were smeared. They invented the term quack to basically discredit anyone who wasn't doing.
I'm a chiropractor. Very well. I know this story very well. One of my mentors, he started practicing in the 60s. And of course, same thing, called him quack. This was like the time where the Supreme Court, like the chiropractors took the AMA to the Supreme Court. And so he actually built a pond in the front of his home and put ducks in there. And he's like, so anytime anyone walks by and is like, there's a quack, it's like, yep, right there, right with the ducks. Yeah. So
I love that. Well, okay. So I guess I could wrap that up. So yes, there's big money, there's big influence like the Rockefellers that funds all kinds of different initiatives and funds medical programs and schools and textbooks and all this type of stuff. And it's pretty obvious, how that money works. People understand capitalism. It's just everyone's trying to make a buck, and the systems are continued that way. So as you get into the 60s, 70s, it turns into the food pyramid. The food pyramid originally didn't have 6 to 11 servings of grain on the bottom, but then the grain and all these lobbyists came in. There's actually even a story of how we couldn't even afford to feed people with the old version of the food pyramid that never came out, because it included animal foods and fresh eggs and milk and meat and vegetables and whatever. And then we're like, well, we have a food program. We have to feed people food stamps, or the hospitals or the nurseries or the military. So basically, well, let's give them the corn, wheat, and soy. Let's give them the 6 to 11 servings of grains. Basically the story that how it goes on from there, it goes to climate stuff, right? I think it's a big smoke screen. We could get into the like methane issues specifically and CO2 and stuff, but the high level version is basically food is a very small contributor. Like animal food is a very small contributor in the big picture. Most of it is from big industry, transportation, coal, just all the big industries. Even the hospital, like in the medical industry, has a bigger carbon footprint than the food industry. It's very obvious it's from these big fossil fuel oriented things and not just a cow on a field. Like ruminants, started from the beginning of time producing methane. It's not a problem.
Yeah, this oversimplified fairy tale that cow farts are warming up the planet is ridiculous. There's been a couple of really not to derive everything from memes, but you see them and you have to have a bit of a chuckle where it's like, people are having avocados in New York City, all year round. It's like, how did that avocado get to you? It drove 3,000 miles from Mexico or some, I don't know how far away Mexico is from New York.
Like
so it's 3,000, 2,000 miles away. So is that potentially adding to the environmental load? And then you have sort of monoliths like Bill Gates, who self-identifies as a medical doctor, and everybody seems to be fine with that self-identification. And, he has been I think he's someone to really pay attention to, because it's sort of come to light recently, I think, that he's one of the largest owners of agricultural land in the States. And he has a vested interest in some of these monocrops, these things like the soy crops, the corn crops, and I don't know if Beyond Meat or Impossible Burger, I don't know if that's his stuff, but we hear those names a lot. And it's like pea protein and corn and soy. And, it's one of the things I find really interesting, especially with this vegan agenda or this plant-only agenda, is that everything wants to look like meat. It's like, let's make a burger. You can't have a real burger, so let's make this chemical toxic soup that looks like a burger. Let's make a tofurkey. Let's make if you want to have plant-based foods, just eat whole plant-based foods.
It's really funny. And yes, Bill is like on this agenda of we need to make fake meat. And he is invested in some of those big companies you mentioned, but I'm sure he has more ideas of the future and why he's buying up all this land. And the largest private holder of agricultural land. It's all very fishy, and it all even the making it into the fake meat. It's like, this just tells me that this is human nature, that humans inherently know they want meat and they want to eat things that taste like it. And they're trying to go around those instincts. Misguided, right? There's this misguided thing. And you can break down veganism. All the three pillars are wrong. It's the moral, it's the environmental, and it's the nutritional. And each side of those arguments are actually untrue when you look into them. So it's kind of sad as they think they're doing it for these reasons. And those are the three main ones. And all three of those are wrong. It turns out when you look into them more past the surface level, they're all wrong.
My genetics, let's say, expect me to be in the sunshine, right? Like Lebanon, Israel, these are, countries with great, very beautiful climates. And of course, you and I, we live in Boston and we live in Toronto. So let's talk about maybe the importance of vitamin D in the body generally. And then maybe this can sort of parse into a discussing about inner age and our genetics as well.
Yeah. So, I think that vitamin D is one of the most important hormones that we have, or vitamins, both vitamin and an hormone. And the major role of vitamin D is to help build the bones together with calcium. But there is a lot of data that show that vitamin D have an additional roles other than that. For example, there is a strong data that show that a correlation between low vitamin D in the blood and the high BMI. So definitely it's related to maintaining your weight and BMI. There is a data that show a very strong data, I think, that came recently with COVID that showed that a subpopulation with a relatively higher vitamin D are dealing with COVID much better than a subpopulation that have lower vitamin D. Definitely there were a lot of information about that in the literature about inflammation and all of that. So the vitamin D is definitely very important based on what I said and what I haven't said. The interesting issue is that, as you mentioned, we were built, if we think about ourselves as a machine, to work under the sunshine and not under the fluorescent light, what most of us are doing most of our time. And the majority of us have a relatively low vitamin D. We can see in our database of InstaTracker that when a user is coming to us, I would say around 50% of them have a low vitamin D, and they don't know about it. So it's very important to know your vitamin D and then to try to use intervention to increase the vitamin D. I can tell you that when I started the InstaTracker more than a decade ago, not surprisingly, my vitamin D was low. And I said, let's try to fix it naturally. So I hate fish because fatty fish have a lot of vitamin D for breakfast, lunch, and dinner. Not to say that my house was really stinky because of that, but also
if you ever figure out how to make fish without making the house stink, I want to know, because every time I make it, for days, it's like, did you have salmon? I'm like, yes, we had it on Sunday. Yeah.
So I'm trying to grill it outside. Actually, that's the best way.
That's smart. Actually, that's smart.
The best recommendation. It's pretty good to grill it outside. But anyway, I tested after a few months, and it didn't move the needle at all. So specifically for me, I couldn't increase it. Now, if you look at the recommendation for a supplementation for the RDA, it's around 400 IU in order to increase it. So I tried that, and again, I tested again and didn't move the needle. I tried 1,000, didn't move the needle. And then I realized after a few trial and error that actually the amount that it's good for me, it's around 5,000 IU every other day to maintain my vitamin D. But it was very hard for me to know that if I haven't been tested myself. So that's a great example to show how you need to trial and error, because our body is so complex and we are so different than one each other that there is no cookie cutter to come and say, hey, take 400 IU, 1,000 IU, or 2,000 IU, or 5,000 IU a day. It's important to take it and then test it and see whether you go to the right range or not. That's what I want to say about vitamin D. And then what we are doing in InstaTracker is we are fitting your vitamin D based on the starting level that you have. I'm talking about the supplementation, and based on what we see that is working for you or not. So it's much more complex to come say, hey, you have low vitamin D, okay, take the supplement and you are good, because sometimes it's not enough and sometimes it's too much. And it's better not to be in too much, even so that for vitamin D, it's very hard to be in too much. But for other marker, it's pretty easy, and you always want to be in the range that is optimal.
Yeah, and that's an astute observation. Because I've had clients who live in Florida, who you're like, oh, you're in a sunny, you live in an environment where you have exposure to a lot of sun, and they're vitamin D deficient. And to your point around, you can't feel, pain is also very nonspecific, but you can't feel your vitamin D levels increasing or decreasing, in the same way that you can't feel your LDL particle numbers increasing or decreasing. These are things that need to be quantified through things like blood work. I wanted to just touch on one more, which I really talk about a lot on the show and with my physicians that I teach, and that is metabolic markers of health. Things like fasting glucose and HbA1c, which are two of the 43 biomarkers that InstaTracker looks at. Can you speak to the importance of why we want to be looking at HbA1c and what that's actually looking at, and then speak to glycation? I mean, you mentioned before, I'm not going to talk about the 18 changes from the resveratrol and the sirtuin activation and all of that, but I would guess, along with inflammation and oxidative stress and membrane, stability, that also things like glycation of the cell is going to decrease as well when you're doing things like caloric restriction and sirtuin accelerators and activators as well.
Yeah, it's a very good question, and I think that if you look at those two markers that you mentioned, glucose and A1C, those are definitely a couple of the most important markers that we have. Just a simple observation that if you look at the lifespan of a diabetic person versus a person that is not diabetic, on average, the lifespan of the diabetic will be around a decade shorter than someone that is not diabetic.
A decade,
yeah. So it's it's pretty big. So so looking at maintaining your glucose and A1C in the right level for your lifespan, and not only when you are old, and it's very similar to what you mentioned about the cholesterol. If I'll go for that for a second, the beginning of the issue that you have with your arteries with a deposit of cholesterol or particle, it's not happening at the age of 70. It's starting from the beginning, from the day that you have been born, your body starts to accumulate that. And because of that, it doesn't make sense for you to be worried about LDL or the particle or ApoB at the age of 70. You need to be worried about that at a very young age. It's like, I see it as like investing for your retirement, okay? So you invest for your retirement from the age, hopefully, if you're smart, from the age of 18 until the age of 67, and then you start using this money. But if you want to do that for your health, so maintaining your LDL, your particle, your glucose, you will reach to that age sick, and then you won't be able to enjoy the money that you save so hard in your lifespan. So going back to glucose and A1C, so if you're looking at glucose, there is a lot of data in the literature that show that there is a strong correlation between having a relatively low glucose in younger age and longevity, okay? So there is a very strong data from a Framingham Heart study that they basically plotted the level of your glucose, fasting glucose, in a specific age, and then they plot the longevity. And what they have shown that basically, if at the age of 40 you have, let's say, glucose of below 40, so below 80, versus around 85, versus around 90, versus around 95, versus around 100, and then you look at the longevity, you see that a subpopulation that have the lowest one, let's say below 80, lived much longer on average than a subpopulation that have a higher level at the age of 40. So what does it show us? Again, that it's very important to maintain your glucose in as lower level as possible from very young age. Now, if we are looking at or talking about A1C, so A1C is basically, it's looking at the glucose, but instead of looking at the fasting glucose or the glucose at that second, it's looking at basically the average glucose in the last 90 days. Because our red blood cells are reborn or destroyed every, let's say, 90 to 180 days, 120 days. So that means that if you look at the A1C, which is basically glycation of the hemoglobin, you can see the trend of how was your glucose, how good you are in the last quarter, let's say. And there is a very nice a range that show that if you have this level at or below that level or above that level, what is your risk basically to have too high glucose? And in that case, you can get closer to become diabetic. So I think that looking at glucose and maintaining the glucose and the A1C in a good level, and there are so many things that you can do because as you mentioned in your question, those are metabolic related markers. So it's the sugar metabolism, the cholesterol metabolism, triglyceride is one between, and also inflammation. All of that is so important for maintaining a good health. And because of that, those are markers. And by the way, those are markers that your physician will look at it all the time. But because of the ranges, as you said, the ranges becoming looser and looser with more and more diabetic and more obesity, that most of us will be in the normal range, but it's still better to be optimal because then you can delay it and make yourself better. So what we have done at InstaTracker, we built something that we call InnerAge, which is basically a solution or a feature that look at those metabolic markers, but also other markers, and try to see how do you compare to someone in your age and gender in the markers that either going up or going down during the aging process. So cholesterol is going up, glucose is going up, A1C is going up on average in the aging. But marker like testosterone, specifically for males, is going down with aging. Every year that a male getting older, there is on average he losing 1 to 2% of his testosterone. So we combine all of that to one score that we call it inner age, and then you compare your inner age to your chronological age, see whether you are younger or older. Hopefully you are younger. But more than that, because we are looking at blood biomarkers, we can come and tell you, hey, your glucose contribute 1.5 years for you to become older. And your LDL cholesterol contribute another 1.5 years. So then you can zoom in into those two markers and come and say, what can I do to change in order to improve those markers? And then we can give you some intervention related to food, to supplement, to exercise, and lifestyle changes.
I know that there's a very famous gene. Everyone likes to pretend like it's a swear word, MTHFR. So let's talk about just even the word methylation. I think is a little abstract for people. It's like, what does that even do? I often describe it as almost like a relay race. Like it's like the baton is CH3, and we're just passing the baton until we get to the finish line. But let's talk about what methylation is and how poor methylation can affect estrogen metabolism and other things in the body as well.
So what you described it is exactly how it should be described, and what nobody describes it as. Everyone talks about the MTHFR gene only because it's the most studied. So if you're not in this space and you're, say, some functional medicine doctor in Ohio that just happened to need a genetic test, you're going to go Google something and you're going to be bombarded with MTHFR articles. And so that's what you think you're supposed to know. Why? Because the research is all done by pharma, going back to the very first thing I said, looking for the needle in the haystack. What's that thing that if I turn this gene on or off, it may only work on 6 out of 10 people, but it's going to turn into a drug for me. So what do we do about the other 4? So the other 4 are the full cycle, meaning that baton pass of FUT2, SHMT1, there's MTHFR, there's a couple SNPs we look at, those spelling mistakes, there's MTR, MTRR. So if you look at the whole cycle, once again, just like we talked about hormones, you can step in at any place in that cycle and know exactly how you're doing that one micro function in this full function. So you know where to intervene, with what and why. A simple thing like folic acid, you get pregnant, you're given folic acid. If you have the suboptimal SHMT1, which a lot of women do, doesn't work for you. You need folinic acid. Your body can't use the folic, but there isn't a single pregnancy tablet on Shoppers Drug Mart or CVS shelf that isn't folic acid. But because again, 7 out of 10 people, 8 out of 10 people, great. But the 2 or 3 that it didn't work on are going to have a horrible outcome. So what is methylation? It's really technically, in general terms, anti-inflammation. That's the outcome. Reduces inflammation. How? A methyl group, a molecule attaches to another molecule. There's certain toxins that are not water soluble. You can't pee them out. And so they require a methyl group being attached in order for your body to get rid of them. There's a signal to like, here's how we get rid of this thing, right? So in that process, there's first the baton pass of methylation, then the tail end of it, and this may be the most important thing I say about methylation that nobody considers, is COMT. So COMT, which we talk about for hormones, we talk about for the brain, for neurochemicals, is also the tail end of methylation. So you can be methylating great. And how many times you have these anomalies where you go again, get some tests done, and you're told, great methylation, don't worry about it. But why am I always inflamed? Why does everything suck? When I get a mosquito bite, it lasts 2 weeks. My friend, it's gone in 2 days. I can't deal with inflammation because that everything, the garbage is all being brought to the door, but the door's closed. You have no COMT. COMT being slow doesn't clear the stuff out, right? So I would almost sometimes start there. Just like when you talk about functional medicine routines, a lot of clinicians will say, well, I'm not going to work on your detox until I get you pooping properly, because there's no problem helping you detoxify when it's not going anywhere. So they'll often start there. Same thing with methylation. Let's open up your compound. Let's figure out what's going on there. Then we'll work on the methylation side. Then you have the exit door open so that this stuff is actually efficiently doing something. To intervene, it's all the B complexes, B12. Is it under my tongue sublingual? Is it in the gut? Is it a methylated version, like you said, or is it adenosine, very different version of B12, which we find a lot of people need? You know, the very simple call it anthropological fact, is that some of our ancestors ate beef and some didn't. So some of us have the ability to metabolize B12 in our gut because our ancestors ate beef, and that's the way the B12 is delivered. But most of us, I don't say some of us, most of us don't. Most ancestries did not eat beef. That's a fairly novel, new Western European phenomenon. Most of us goat, sheep, lamb, poultry, fish, vegetables, plants. That's what our ancestors ate. And so we are wired to metabolize and absorb B12 under our tongue sublingually as we chew. That's why grandma says, chew your food, because that process of taking in micronutrients literally starts in your mouth. So if you start to understand these things, you can be so precise and just get rid of the headaches and all that trial and error and just do what you need.
And one of the things, so COMT, the gene that you're referring to, is catechol O methyltransferase. So as the name suggests, it's transferring methyl. Also metabolizes things like dopamine, like other catecholamines, right? So the dopamine, epinephrine, et cetera. And this is often called the Worrier gene. Yes. Which I remember you and I, we had a conversation many years ago about this maybe being like an entrepreneurial gene, because I think I think being an entrepreneur, and this is for the clinicians who don't identify, you are, let me just break the news to you right now. You are an entrepreneur if you are in practice for yourself. Maybe, if you're a medical doctor, it's a little different, but if you are a naturopath, a chiropractor, physical therapist, osteopath, you are also an entrepreneur. Like, what crazy person, how crazy do you have to be to go against the grain, to not get a safe job working for someone else with benefits and say, you know what? I'm going to change the health of my community. I'm going to open up a practice. I'm going to be not only the boss, I'm going to be the technician who delivers. I'm going to be the HR. I'm going to be marketing. I'm going to be sales. I'm going to put all this together and it's all going to be great. So can we talk a little bit about how the COMT gene is, and we can maybe start talking a little bit about brain health in here as well, sure. Because I think that this is also, when I learned about my own COMT gene, I'm heterozygous for it. So I was like, oh, that's how I could, for long periods of time, sit down and study. Like I could sit down and focus on something. And I also have a proclivity for taking not big risks. Like I'm not like the super entrepreneur, like the serial entrepreneur that like starts 10 businesses. But I've started a few and they've all been relatively risky. So can we talk a little bit about how the COMT gene interacts, let's say, with our metabolism of dopamine and some of the other catecholamines?
It's time for a rant. I'm going to go off on a rant now, because when it comes to the brain, that's my favorite part of what we do, because, kind of like what we talk about female hormone health, it's underserved, but it's also just not recognized. So at least the women know that they have a problem and they're asking for help. When it comes to this stuff, people have no clue what's right, what should be right, what's wrong, what should be wrong, all that stuff. So starting with COMT, but the profile you described, I'll use that as our avatar. Sure. The graduate who's opening their own clinician, and what does it take for that person to succeed? And if they don't have it, what do they need to do? Right? Because it doesn't mean they can't achieve it. They understand what equipment they've been given. If you buy a Ferrari, great, you bought a Ferrari. If you take it off-roading, it's not so great anymore. It's going to fall apart. But if you take an SUV off-roading, it's going to do pretty well. They'll actually beat the Ferrari. So understanding what your innate capacity is, and we're not all the same, and then putting yourself in the right context. That's how you thrive. And if you're in the wrong context, you need to know so you can either change it or adapt and add the tools you need. So starting with COMT, yes, it clears your dopamine pathway out, or the dopamine itself out, sorry. You start with first, when it comes to mood, we see things in three phases. The anticipation. I smell the tasty pizza. I know it's coming. The feeling. I bit into the tasty pizza. Oh, wow. The clearance. Go back to normal of going to work or whatever I was doing before, right? That's how you experience most things. If I use COMT, so first DRD2, the dopamine pathway determines to what degree do you actually bind dopamine. So when that thing starts, are you binding it efficiently? Are you actually anticipated and excited? Or are you stone cold and you don't feel? When it actually happens, did you feel it at the level of the peers around you? Like, this is amazing. Like, yeah, it's okay. Right? Because you just can't feel. And then while they're still enjoying the meal, are you now on your phone distracted by something else because you're comped is so fast you can't stay in the moment long enough? So if that's you, you're a warrior. You know, 3 outcomes: depression, because you don't feel; addiction, because dopamine powers pleasure, and you go down this route of something that finally gives you that hit. That's such a wow factor that you do it and you do it and you do it and you structure your day around it. You do it more and more and more until you kill yourself. Or achievement, because dopamine also powers reward. And you only need to do one of the two to feel satisfied. And so you go down this reward route and you take risks and risks and risks and risks. And then the reward from the risk feels so good that the failures don't really matter. So that's the avatar of the person who is reward seeking if they were in the context of needing reward. That same clinician that was about to open the practice, that was willing to put their money on the line and go start a brand and do all the stuff, taking a risk, could have also gone down the depression route because they didn't have that option in front of them, don't feel satisfied with what's going on, and just fall apart. Why do you see so many high-level people, Anthony Bourdain committing suicide, Olympic athletes killing themselves, high optimal achievement people? Because the second they're not getting the hit, depression. They're not wired for pleasure, right?
And
so
it takes so much to activate those dopamine receptors as well.
Yes,
like they need so much. Yeah.
And that's why they achieve so much, because they have to. They have to take risks. They have to go way beyond what everyone else does to get the same level of hit, to maintain some level of satisfaction. So now, on top of that, you talked about, but these people also wear multiple hats. They're the marketing person, they're the podcaster, they're also the clinician, they're also receiving the legal letters in the mail, right? So there's a certain profile that can do that. You talked about BDNF, brain-derived neurotrophic factor.
Yeah.
That's that gene that determines how well you deal with neuroplasticity. Your brain developing neural connections that, the synapses, that information flows through these highways of your brain. And this one gene will determine how efficiently you develop these connections. So for some people that are highly efficient, and you'll often see this in the warrior high performance category, they do a really good job with that. So not only can they develop a lot of skills, but at a masterful level. They're never call it a PhD of any of them. They're not the true thought leader in them, but they can do 85% of everything, which makes them this multi-hat wearing entrepreneur, right? It's very easy for them to shift gears, learn new skills, and they have the fast comp, which allows them to multi-prioritize and not get stuck in a particular reward or experience. They can move on to the next one, right? The opposite, if you have the low BDNF, you're more a specialist, tunnel vision. This is what I do. Don't move me from my desk, right? I'm not going to talk about it. I'm not going to write about it. This is what I do. But they are a true thought leader. They do it better than anybody. They needed an assistant for every single step of the way. They can't do, literally, the thing they do is all they do. You get an email from them, it's probably 3 pages, and it could have taken 2 lines because they think so deep about everything they do. But that person can't wear the multiple hats. They can't be an entrepreneur, right? They can't even burden the thought of, I have to think about legal, I have to think about marketing, forget it. Somebody else do all that. Think about the scientist in the lab. Right?
I was going to say the researcher or the academic. Yeah.
Yes, the academic, perfect example. I do this better than anybody, but don't ask me to even go to the other room to talk to people. This is what I do. You do it in this room, right? That's how tunnel vision it is. And then, there's variability in between. So these are the kind of the 2 extremes. So entrepreneurs are usually on this end, but you will find that random, unique person who's on the other far end that happened to build the team around them. Different reason for their success. They had they were the IP, but somebody else built everything around them, right? Now that's another serotonin. Serotonin is often spoken of for your mood. How do I feel? Your mood regulator. And there's supplements like 5-HTP that people take to modulate or regulate their serotonin uptake and how they feel. It does a lot more. So yes, your mood, what it actually does and why it affects your mood, it determines how well your brain prioritizes stimulus. So when we're sitting here talking, there's been several times where there's been a kid walking by the window, and I've noticed it every time, right? I've learned to focus, but I have the shortest possible serotonin receptor, which means that every single detail and nuance stands out to me. Everything is irritable, everything is bothersome, everything is frustrating, and I read into things at a depth and level that people didn't even see. So when we're sitting here in the room, having a meeting, talk about 10 things, not only do I remember the 10 things, but I remember what page of your notebook you wrote the note on when next week you say, we didn't talk about that, right? That being said, it's a little bit too much. I have to meet people.
So you need a quiet environment to study. Like I remember if someone was breathing the wrong way in university, like we would, like in this communal kind of study area, I would have to get up and move. I was like, I can't, this person is so loud. I can hear the air going up their nostrils. Like I can't, like I needed total silence. And Giovanni, my partner, who you know as well, loves background noise. He always wants music on. He always wants like white noise puts him to sleep. I need dead, dark room, dead silence room. He likes like whoosh, like he likes like noise.
Now think about Giovanni.
Yeah.
Zen, cool, things don't get to him. Why? The exact same stimulus that you and I are experiencing, his perception truly believes it's about 40% of what we think it is.
Right.
He doesn't even hear the thing that's bothering us.
Right.
When people talk to you, they literally, when people walk into the room to tell you something, they have to think twice about how they're going to say it, right? Because they know they can very easily frustrate you, bother you, derail you, distract you. With Giovanni, it's just like throw it on the table and he'll deal with it.
I feel seen. I feel seen.
And that's what it is. It's it's literally a reptilian part of our brain. So picture the snake that's sitting there. There's no maybe for a snake. It's either no or attack. You put your finger towards it, just all of a sudden bite, right? There's nothing in between. And that's what serotonin does for us. It's this response to stimulus. What should I prioritize and react to? And if your receptor is shortened, then all of a sudden your brain doesn't know what to prioritize. And every clock ticking, every hunger pang, every noise, every whatever, everyone chewing their food the wrong way, which I'm sure you don't like, it all is a problem. But when you're doing your work, and this is why it's so valuable to an entrepreneur, is every little detail matters. Every T, every I, you read an email, you know exactly everything that they said, and you don't forget dates, et cetera, et cetera, et cetera. All this stuff that if you're going to go build something, the new practice, you need to have this. Now, if you know that you don't, you need to have the right people around you.
Interestingly, the way that fructose is metabolized is the identical pathway by which we metabolize alcohol. And what your friend, Dr. Robert Lustig, has said is that fructose is alcohol without the buzz. And I love that because, it offers us up nothing. I mean, our nutritional requirement of fructose is 0. And yet, look what's happening now. But you quite correctly identify glucose as the molecule for energy production because it does allow through the Krebs cycle the production and glycolysis as well, the production of these ATP molecules, whereas fructose is the molecule of energy storage, getting ready for use of energy in the future. And while their chemical formula is exactly the same, they are structurally different, and they are as different as night and day. It's unfortunate that, it's fructose sugar, lactose sugar, glucose sugar, they're all sugars. We sort of look at them, we studied them on the same day in biochemistry class, but they are so different. And glucose metabolism is an energy producing, it's something that allows us to metabolize. Whereas the production of energy storage is what happens when fructose is metabolized, whereas glucose produces these ATP, currency of energy molecules. Fructose actually takes ATP and reduces it down to AMP, and therefore depletes intracellular phosphate, and that is a huge event. That change from ATP to AMP, adenosine triphosphate down to adenosine monophosphate, that depletion of this intracellular phosphate, signals our bodies to prepare for winter. It changes our entire metabolism away from energy utilization to energy storage. And it is what happens, for example, in a bear. If a bear is as bears prepare to hibernate, they turn off a certain pathway that's called AMP kinase, which would otherwise keep that bear lean and mean, fighting machine. And it shifts that metabolism over to AMP deaminase. And what AMP deaminase does is it says, raise the blood sugar become insulin resistant and make a lot of fat. And that's what the bear is doing by eating fructose left, right, and center. 10, 20 pounds of berries in a single day to get ready to store that fat so that he or she can survive during the time of hibernation. Then during hibernation, the animal is tapping into its energy resource, which is the body fat, and using that energy resource as a caloric depot, and also, interestingly, as a source of metabolic water. When the bear or you or I burn fat, we're creating water in our bodies. So this body fat that it stores is not just a calorie resource, but it's a resource to make metabolic water, because it doesn't eat all winter when it's hibernating, nor does it drink. And it explains why, for example, the camel, I love this example, it's walking across the desert for weeks at a time and doesn't drink any water. Why? Because what is the most identifying characteristic of the camel? The hump. What's inside the hump? It's not water, it's fat. So it has a resource for energy. It has a resource to make what's called metabolic water, like whales do, like the hummingbird does. The hummingbird, when it's getting ready to fly from where you live to where I live, is 40% body weight fat. And that's its resource, not just for calories to make the epic journey, but for water as well, metabolic water. And if you want hummingbirds in your backyard, what do you put out there? You put out sugar water. It's fructose that tells that hummingbird, get ready for your epic journey. Same thing happens in your body and my body and in the body of everybody on the planet. And that is that we are very parsimonious or thrifty as it relates to the calories that we consume, specifically those signaling calories, which are the sugars and specifically fructose. Our Paleolithic and even our primate ancestors would eat these berries and other fruits in the late summer and in the early fall because they were sweet. And that's why we like sweet to this day. There's nobody who will tell you, no, I don't like sweets. We choose not to eat them because we know they're bad for us, right? But we like them. So we all have that sweet tooth cooking in the background, but we're bringing on our prefrontal cortex saying, yeah, I really want to eat those sweets, but I know it's not good for me. Would I like to drink a Coke? I would. I absolutely would put a Coke, drink a Coke, pour it over ice, have a straw. That would taste, I would still probably enjoy that, or a Dr. Pepper, one of my favorites. But yet, that's my amygdala brain saying, sweet, seek it out for survival. That's going to help you live. My more adult in the room part of the brain is saying, yeah, but you don't want to do that, do you? You know what that's going to do to your insulin levels, what it's going to do to your fatty liver, increasing that, and all the stuff. So we override these primal instincts. Those primal instincts allowed us to survive because sweet prepared us for winter. Sweet identified fruits as being safe. There aren't any fruits that are sweet that are harmful for us. They're not, there's no poisonous sweet out there. So we refined our genome and our brain wiring to give us this desire for sweet and the little dopamine rush that we get when we eat it. But nowadays, hopefully, we are able to bring on board our prefrontal cortex and override the amygdala and make better choices. Getting back to a conversation you and I had last time I was on your program. So it's a very interesting story. And I have to tell you that my interest in this evolutionary environmental mismatch, that's what our problem is now, that we've evolved with this desire for sweet and this ability to make fat when we eat that sweet in a different environment of food scarcity, an environment in which we might be threatened as well. When we were hungry, not only could we not find food, but we might be eaten by an animal that notices that we're kind of staggering around, can't make good decisions because our brain isn't powered. We evolved these mechanisms to make sugar to power our brain. So we have this evolutionary environmental mismatch today where our environment is giving us all this fructose. We don't need to do much in our physical world. We don't have to sleep very much, or we choose not to, rather. So this evolutionary environmental mismatch has been something I've been interested in for more than half a century. I wrote my first article about this, published it in 1971 when I was 16 years old in the Miami Herald. And I asked the question, what about us who are living today with this outdated machinery? That was my conclusion, because we're not going to evolve quickly enough to be able to tolerate the fructose, the sodium. We'll get to that. The high level of purines in our diets, and certainly the alcohol that we are consuming.
All right. If you enjoyed that conversation, you are going to love the next video that I have queued up for you. We are going to be talking about eating for energy, mental clarity, and weight loss. It's right there.
Manufacturers feed us so many lies, and it's not just the manufacturers. The government is telling us to do that because the government is lobbied by the manufacturers.